Hello everyone, I am Dr. RMD, and for this preparation for NEET PG 2026, what I have realized was students are facing it difficult to remember things, remember images, remember things based on photogenic memory, because all the concise sources like revision source or maybe BTR or many such sources have information in the form of words which are difficult to remember. So I came up with such a source which is easy to remember and you can complete it in a given amount of time also. So as a first part of it, I have started with Pathology, the Endgame. If you haven't watched the prior video, introduction video, please watch it. You'll get an idea on how to use this PDF and this book, and stay with me throughout the journey and you will realize how important this source is for preparation. So we have named it the end game because this is what exactly you need on the day of NEET PG exam and nothing else. So we have started with pathology. This PDF was framed by me and my teammate Dr. Rupal, and we have all these unique features in this. So I had prepared a timetable for NEET PG students for 2026 in which we had started with patho, and that's why I'll be starting with patho revision videos today. So what is there in this? In addition to this, what do you need? You need what we have considered is total 80 high yield topics list. Okay, these are mainly PYTs. And in addition to this, you will require PYQs, which will have to solve from any of the coaching platforms. And along with this, you'll have to give regular GTs. And that's it. Okay, so let's start with our syllabus. So first topic is acute inflammation, which has been repeatedly asked in before this. Okay. Let's start with the image-based explanation only. So I have made this cute images for you to remember. Okay. So each specific point in this image has a meaning. Okay. It is not simply framed. It has a lot of meaning. So let's start. What are the cardinal signs of inflammation? Every one of you know. So I don't have to go in depth. So here you'll see these are the three molecules involved in inflammation. That is, one is histamine, second is prostaglandin, third is leukotriene. Histamine is for vasodilation, very important molecule. Prostaglandin is for increasing temperature. Prostaglandin PGE1 helps in temperature increase, and third is leukotrienes. Okay, so what is the process of inflammation, acute inflammation, that takes place anytime there is an injury? There is vascular change. So first is vascular change. There is increased vascular permeability. See, these neutrophils and these mast cells are releasing some molecules, okay, which are causing the vascular vessel to swell up. So this is nothing but vasodilation, as a result of which many other agents, many other chemical mediators are coming near the endothelium wall. So first cellular response in 6 to 24 hours is via neutrophils. It is not by lymphocytes, it is by neutrophils. And what helps neutrophils come to the site of injury? It is nothing but this chemotaxis. So there is chemotaxis. There are some chemicals, and which are these chemicals? C5a, IL-8 and LTB4. Remember these three molecules, these are repeatedly asked question. Now when these neutrophils come nearby, they go near the endothelial membrane. This is known as migration. Okay, migration, and we call it as margination. Okay, now once margination is done, they will roll on the surface of the endothelium, and this is mediated by selectins. Okay, selectins mediate rolling, and then they adhere to the endothelium wall, and this adhesion is mediated by what is known as integrins. So selectins are different and integrins are different. Now after that, there is phagocytosis and killing of the microbe. Now entire process of inflammation has three outcomes. It can either go into resolution, many more inflammatory cells can come and it can cause an abscess, or it can lead to fibrosis. These are the three outcomes of inflammation, acute inflammation. So what are the various patterns that we observe? One is the serous pattern. Okay, so there is only fluid, there are no cells in this. Okay, so like for example, pleural effusion. Okay, we see transudative pleural effusion. Transudative, that is a type of serous inflammation. Next we see fibrinous, where there is a lot of fibrinous, like for example in empyema we see fibrinous. And then we have suppurative. Okay, suppurative is when this pus and abscess collect in the tissues, okay, in the cavities. So we have some other types of inflammation also. For example, where there is pseudomembrane like formation, that is seen with infection with Clostridium difficile, and there is ulcer formation also, which is necrotic tissue. Okay, slough of necrotic tissue. Now because of this inflammation, what clinical aspect we should know? One is about steroids. Steroids inhibit phospholipase A2 enzyme. There is arachidonic acid which lead to prostaglandin synthesis. Okay, these prostaglandins are involved in inflammation. Okay, so what steroid does? The steroids inhibit this phospholipase E8. Are you seeing this enzyme, phospholipase E8, and NSAIDs inhibit this COX enzyme. COX is nothing but cyclooxygenase. Okay, so these two are asked questions. Next, what is this thing? This is nothing but you'll have to remember certain thing, that is lymphocyte is not involved in acute inflammation. It is always the neutrophils, and neutrophils are coming within 6 to 24 hours. Okay, and what is this C5a? Why C5a is very important? I'll tell you in the fill in the blanks. And what is this molecule? Integrin, and integrin defect leads to LAD. What is LAD? LAD is nothing but leukocyte adhesion defect. And if you are a very good student, you will know what does leukocyte adhesion defect cause. Yes, LAD type 1, it causes delayed umbilical cord separation. Very good, very good, very good. Okay, so now this one image has every information that is required for you to solve questions in NEET PG. That's why this particular image, particular slide, hardly takes 30 seconds to go through, will answer 4 to 5 of your NEET PG question. That's why I call it, this is a game changer in the field of revision. So now we'll go to some fill in the blanks so that you increase your recall power. Okay, so which molecule is involved in vasodilation? Yes, very good, histamine. You saw, right? I had an image of histamine causing vasodilation. Next, which are the first responders? Very good, it is neutrophils and it is not lymphocytes. Chemotaxis is caused by C5a, IL-8 and LTB4. Rolling is mediated by what? Rolling is mediated by selectins. Adhesion is mediated by integrins, and this integrins defect causes leukocyte adhesion defect. Okay, and what pseudomembranous inflammation is caused by? Clostridium difficile. So please mention in your book, in your PDF, wherever you have opened this, just write all these things. You will never forget. Which is the strongest chemotactic factor? That's why I have mentioned C5a separately, because it is the strongest chemotactic factor. It calls all neutrophils and lymphocytes. What blocks prostaglandin synthesis? Very good. NSAIDs block prostaglandin synthesis via COX enzyme. And what blocks phospholipase E8? Steroids. So that's it. That's the important thing that we need to know about inflammation, and we are done with it. Okay, now we'll move on to next topic, that is cell death, apoptosis and necrosis, and intrinsic and extrinsic pathways of apoptosis. This apoptosis versus necrosis is a very confusing topic and many students get it wrong. That's why I'll make it very simple and very easy to understand for you. Okay, so see these things. Whatever is given in blue is apoptosis and whatever is given in red is necrosis. So we'll go through apoptosis. What is apoptosis? Apoptosis is when cell by its own will it tries to destroy the cell. Okay, so it's a programmed cell death. Everything is programmed, and when everything is programmed, it needs energy to do so. Okay, so when does apoptosis occur? Whenever there is mild physiological injury or there is some mild physiological process is taking place where we'll see the examples also. So that time what happens is, important one enzyme which is involved is caspases. Okay, caspases are involved in apoptosis. Caspases are involved in apoptosis. Remember this. Now what will happen is a series of steps take place, which we'll be seeing. Okay, there are two pathways in this, in apoptosis. One is intrinsic and one is extrinsic. Okay, I'll explain you both in detail. Okay, and you will never forget this anytime. Okay, so in both this apoptosis pathway, what happens? A series of steps happens, and then nucleus is broken down. Okay, and then formation of apoptotic bodies also happen, and nucleus is also broken down. And this nucleus, now whenever you are doing electrophoresis, it appears like step ladder pattern. This is known as DNA laddering. Okay, so at the end of the thing, what you get apoptotic bodies, and you get so much intact cells and all, which are finally lysed by the macrophages, and everything goes. So there is no mess created. Okay, it is not a messy process. In contrast to this, necrosis is totally different. Necrosis is very messy. Okay, so whenever there is severe injury or somewhere ischemia happens, like example in myocardial infarction, what happens is cell gets damaged. Because of this, ATP gets decreased. Now this ATP depletion causes lysosomal rupture. Okay, there are multiple pathways in this again, and because of this lysosomal enzymes get released and they cause nuclear damage. And there are three steps, very important steps to remember, that is pycnosis, karyolexis, karyolysis. Now what do these three mean? Pycnosis means this nucleoli, they get condensed. Okay, this is known as condensation of nucleoli, known as pycnosis. Karyolexis means there is fragmentation of DNA. Okay, and karyolysis means the whole DNA is broken apart and they are like scattered everywhere. Okay, and now because of this scattering of all things everywhere, everything is messed up, so there is pro-inflammatory response. Okay, and there is leakage everywhere. So this is a very messy process. Now what are the regulators? Always in apoptosis, there is one molecule which stands always, and that is BCL2. BCL2 doesn't help you to undergo apoptosis. So it is anti-apoptotic. It is like the police. Okay, it doesn't help murder to happen. Okay, it doesn't allow suicide also to happen. So apoptosis is like suicide. It doesn't allow suicide to happen. Now, why we have mitochondria? Because mitochondria is the starting point of all this apoptosis. Okay, and what is this fast and fast cell? I'll tell you in detail now. In contrast to ischemia, what happens in ischemia? Ischemia, there is direct nucleus, everything will break down. Okay, so what are the examples for apoptosis? We have embryogenesis. During embryogenesis, some cells, like for example, web of the fingers, they get dissoluted. No, so cells die. So those undergo apoptosis. Similarly, in chemotherapy, cells undergo apoptosis. Whereas in infarction, okay, there is necrosis, and because of necrosis there is high LDH, because cells breaks down and LDH, which is present in the cytoplasm, that gets leaked out. So during karyolysis, what happens is, in apoptosis there is DNA laddering. Okay, and in apoptosis there is DNA laddering, and in there is smear formation in necrosis. Okay, but karyolysis occurs in which? Necrosis. That's why in necrosis there is, in karyolysis there is smear formation, that is necrosis. Karyolysis doesn't occur in apoptosis. That you have to note it down. Okay. Next, where you go wrong, you think that apoptosis has no inflammation. That is the correct. Apoptosis doesn't has inflammation, and necrosis has swelling and rupture. Okay. So this is briefly about apoptosis and necrosis. Now let's go one step ahead into apoptosis, various types of apoptosis. That is, one is intrinsic pathway and second is extrinsic pathway. Now intrinsic happens in mitochondria. That's why this mitochondria symbol, and extrinsic happens because of other signals. What are the examples you see here? Intrinsic, in embryonic development it is intrinsic, and if there is any viral response and then you want to sell see, this is the virus infected cell, and our T cells are going to kill this cell. Okay, virus engulfed cell. So this is an example for intrinsic apoptosis. Similarly, for extrinsic apoptosis, immune system regulation, like for example some cells are going out of control, so that immune system regulation is extrinsic pathway, and tumor suppression is also extrinsic pathway. So these both are types of apoptosis only. Okay, so now we'll go little bit into depth. Okay, see, in intrinsic pathway, it happens inside the mitochondria. Whenever there is mild cellular damage or some stress, okay, within the cell, it releases a protein known as BH3 only proteins. Now there are only few things which you need to remember, which are pro-apoptotic. Okay, pro means favors apoptosis, and which are anti-apoptotic. Remember, there is only one police in the entire story, and that is BCL2. BCL2, MCL, wherever Cl comes, no, all those are police. Okay, so they don't allow apoptosis to happen. Rest everything, back, BH3, BID, okay, all these are pro-apoptotic. So these all want to create riot. Okay, they want to cause more suicides. Okay, so whenever these BH3 proteins are more, what they'll do is they'll cause release of cytochrome C, and this cytochrome C, remember cytochrome C because this is important for clinical aspect. Now this cytochrome C will activate many things, and it will activate something known as caspase 9. Remember I told you caspases cause apoptosis. These are the enzymes which cause apoptosis. So this is the initiator. Okay, this is the one which starts the process. So this is the initiator for intrinsic pathway. So what is the initiator of intrinsic pathway? Initiator caspase, that is caspase 9. Similarly, what happens in extrinsic pathway is some extracellular signals come. Okay, they are known as extracellular death ligand. It is also known as FASL, or it is also known as TNF. Remember these two terms, FASL and TNF. What this causes, they sit on this death receptor and they activate many other enzymes, and finally it leads to activation of this something known as caspase 8. Okay, so caspase 8 activation. So which is the initiator caspase for extrinsic pathway? It is caspase 8. So remember, there shouldn't be any type of confusion hereafter. In intrinsic pathway, initiator caspase is caspase 9, and for extrinsic pathway, initiator caspase is caspase 8. Okay, there shouldn't be any confusion. So now all this combine into something known as executioner caspase. And which are the executioner caspases? 3, 6, 7. Remember these 3 numbers, that's it, okay? And they cause the apoptosis pathway. Everything later on happens because of that, okay? So now what are the clinical aspects related to this? There is something called a cytochrome C staining and tunnel assay, which are helpful in apoptosis. Now what is cytochrome C? See, you saw this cytochrome, right? See, cytochrome is released. Actually, cytochrome, where it should be? It should be inside the mitochondria, but now it is coming outside the mitochondria and it is staining the cell. So it is in the cytoplasm. That is known as cytochrome C staining for apoptosis, not for necrosis. And second is the tunnel assay, where you will see these DNA fragments which are there outside the nucleus, okay? So this is not, tunnel is a long term which you don't have to know. You should just know that it is for DNA fragmentation in apoptosis. So I think everything is clear. So now let's go to the fill in the blanks. Now there shouldn't be any type of confusion. So what type of DNA pattern you see in apoptosis? It is laddering of DNA or step ladder pattern, okay? Pycnosis, what happens after pycnosis? In necrosis, what happens? Pycnosis, karyorrhexis, and then followed by karyolysis, okay? No confusion, okay? What activates extrinsic apoptosis? 2 things, FAS-cell and TNF alpha. Remember this. See here. See, FAS-L and TNF alpha. Okay. Next. What blocks mitochondrial apoptosis? I said there is only one police in the entire story. What is that? BCL2. Next. Which are the caspases? Caspases are involved in apoptosis, and there are 2 caspases, initiator caspase. One is caspase 9 and one is caspase 8. 9 is in intrinsic, 8 is in extrinsic. Okay. These are initiator caspases. Dash overexpression leads to apoptosis inhibition, that is same, BCL2. Next, which pathway activates extrinsic apoptosis? Again, same thing, that is TNF alpha pathway activates extrinsic apoptosis. So this is all you want to know about apoptosis and necrosis and intrinsic and extrinsic pathway. I don't think anyone has made it so simple for you in a so easy manner, okay? So next we'll see chronic inflammation. Again, an important topic with regard to acute inflammation versus chronic inflammation. So you had seen that neutrophils were important components of acute inflammation, but here it is always the lymphocytes. Sorry. Okay. There is also one more thing I want to make it clear. This image in your PDF and book may be the apoptosis image, which was inserted by mistake due to clerical error. That's why you focus on the video for now. So lymphocytes in chronic inflammation, they secrete IFN gamma. This interferon gamma is the reason what attracts macrophages. So the key behind chronic inflammation in NEET PG question is always on interferon gamma. So never forget this molecule, okay? Now this macrophages get converted into epithelioid cells. Epithelioid cells get converted into giant cells, which are bases for chronic inflammation, which secrete antibodies, then plasma cells. All these chronic damages happen, okay? So what is the basic idea behind everything? For chronic inflammation, there is some chronic persistent insult that is happening, which leads to macrophage and lymphocyte activation via IFN gamma, interferon gamma. Then there is granuloma or fibrosis formation, and finally leading to organ dysfunction, okay? So persistent chronic insult, it may be some virus, like example hepatitis C, or it could be some chemical or drug mediated, okay? So this activates all these macrophages, inflammatory cells, then comes tissue damage, then causes fibroblasts to proliferate, then comes angiogenesis, collagen deposition, everything leads to fibrosis. So what are the outcomes of chronic inflammation? It can lead to calcification, it can lead to organ dysfunction, it can lead to fibrosis, or it can lead to cancer risk. So these are the outcomes of chronic inflammation. It can be asked as MCQ question, okay? Now, which are the 2 types of inflammation that you know of? One is chronic acute inflammation. Similarly, what are the 2 types of granulomas, okay? Whenever there are epithelioid cells, there is granuloma formation, okay? So this is what is known as caseation, okay? This is an example of TB. TB causes caseating necrosis or caseating granuloma. Only thing is TB. One more thing is histoplasma, which you can remember, but the only thing that matters is TB. So if there is a pink necrotic eosinophilic material inside this, no, then it is caseating granuloma, okay? So these are the epithelioid cells outside, okay? So if it is non-caseating, there are cells inside, okay? There is no caseation. It is seen in classical example is sarcoid, okay? One more example is Crohn's disease. So when I tell caseating, it is always TB. If it is non-caseating, it can be sarcoid or it can be Crohn's disease, okay? So neutrophils have no role in chronic inflammation, and granulomas don't occur in acute inflammation, okay? And thinking that all granulomas are caseating is also wrong, because we have non-caseating granuloma, that is sarcoid. So now let's fill up the blanks, okay? So what are aggregated epithelioid macrophages known as? Whenever there there are epithelioid macrophages aggregated, that is known as granuloma. So this is a granuloma. Okay. Now, what are the mediators which activates macrophages? It is nothing but interferon gamma. Next, what are the examples of caseation? Examples of granuloma. One is TB, which causes caseating granuloma. Non-caseating granuloma is caused by sarcoid, and we'll also see in Crohn's disease. And there are many examples also, but these are the ones which you must remember. Next, what drives Th1? Because this granuloma comes from this Th1 inflammation, okay, that activates T cells, and that is caused by IL-12. Okay, so remember this IL-12. Once in exam it was asked. Caseation, TB, non-caseating, sarcoid, and Crohn's. Okay, so that's all about chronic inflammation. Next, we'll go to important topic, CRP. So CRP may come as a question. Okay, so important thing is CRP is secreted by the liver. Okay, it's not secreted by the endothelium, not by blood or anything. It is by the liver, and it is increased whenever there is chronic inflammation or acute inflammation also. Okay, so which molecule helps? IL-6. That's why everywhere you will say IL-6. Whenever there is inflammation, IL-6 causes CRP to increase. Now CRP increases within first 6 hours, then it plateaus by 24 to 48 hours, then it starts decreasing as the inflammation subsides. Now very high values of CRP, where it is saying that this is nothing but very high fever, that is sepsis, or flare up of any autoimmune diseases, okay, like SLE flare up, okay, we'll see CRP increasing, or it can be seen in infections such as pneumonia. Now, what is the use of HSCRP? HSCRP is for predicting cardiovascular risk, okay. Next, CRP is basically to monitor whether infection is settling or not. Like after some infection in hospital, you want to see if the infection is improving or not. You will see CRP trend. Okay. So CRP versus procalcitonin. Procalcitonin is more useful nowadays. That's why we are doing procalcitonin also. Procalcitonin is more specific also than CRP. CRP is not specific for which diagnosis it will increase. So in all type of infection, all type of autoimmune flare up, it will increase. So we'll compare CRP with a baseline. Okay. So and when patient comes, some baseline CRP was there. In comparison to that, how much it has increased, we'll check that. Okay. Now, CRP's function are two functions. One is opsonization. It makes the bacteria more tasty for the, it is very tasty, so yummy. So the macrophage will try to engulf it, and similarly, it will cause complement activation for bacteria to kill. Okay. Now, CRP and ESR. Okay. When it comes to certain aspects like in anemia, ESR will increase. Okay, but CRP won't increase. That's why CRP is considered better marker of inflammation when compared to ESR. So we'll solve questions. What produces CRP? Liver produces CRP. CRP rises within how many hours? Within 6 hours it rises and plateaus by 12 to 24 hours. More reliable than ESR because ESR decreases in conditions like anemia. Markedly high CRP is seen in sepsis. Mildly elevated CRP is seen in obesity. Okay, these are the questions. Okay, there are many conditions where CRP is increased highly, but from NEET PG point of view, we have sepsis. CRP is unaffected by anemia. Okay. Anemia doesn't affect CRP. DASH drives CRP synthesis. What drives CRP synthesis? IL-6. HSCRP predicts cardiovascular risk. If low CRP with severe infection, which means even the infection is there, still CRP is not reducing, means there is some form of immunosuppression. Okay. So a simple concept, never to make mistake. Next topic is healing and repair. Okay, so healing and repair has two outcomes. One is it either goes into regeneration, that is cells are regenerated, or cells die and it undergoes fibrosis. So what decides whether it will go into regeneration or fibrosis is the cell type and its potential. So there are three types of cell. One is labile, stable, and permanent. So labile and stable have property of regeneration. It just depends whether the cells are quiescent or not, like skin cells. Okay, they are skin. Gut cells. Okay, so these have regenerating capacity. Okay, even though there is no stimulus, they'll regenerate. Stable cells, like for example liver cells, okay, they're quiescent. If there is a proper stimulus, then they will regenerate. Okay, so these both, they will cause regeneration. But there are permanent cells like neuron and myocardium. If something happens to myocardium, for example, then it will undergo fibrosis only. There is no regeneration, leading to scar tissue. Okay. So what are the steps of this regeneration and fibrosis, that is healing? First stage is lasting for 3 days. There is injury and there is inflammation. You'll see all these inflammatory cells have come over here. Okay, so this is stage 1. What happens in stage 2 is blood vessels start proliferating, and this is known as angiogenesis. Whenever there is angiogenesis, that time we call it as granulation tissue, means new blood vessels are being formed, and the key molecule for angiogenesis is VEGF. Now remember, this VEGF is such an important molecule. You will see it in many images. Okay, so VEGF is such an important thing. Third is remodeling, that is after weeks to months this tissue gets reorganized and everything gets over. Okay, and fourth is scar formation. Suppose there is no regeneration, then collagen is deposited, okay, in the scar, and it will form scar formation. Okay, so now granulation tissue, which are the factors that help in granulation tissue formation? One is TGF beta and second is platelet derived growth factor. Now these, what will happen is when there is scar formation and all, there will be first type 3 collagen. What is this? This is collagen. Okay, there are 2 types of collagen, type 3 and type 1. Remember this, type 3 and type 1. First collagen which forms is type 3. You are seeing this thin threads. This is thin collagen, okay, thin, very thin. So this is type 3, and later on it type 1 collagen gets deposited, that is very thick collagen. Okay, this is very thick collagen. Okay, so first comes 3, then comes 1. Now you don't need to make mnemonics and all, because you already have an image in front of you. You will never forget this. Okay, so there are 2 abnormal outcomes of scar formation. That is, one is excess of thick collagen if it is deposited. Okay, it is known as keloid. Okay, keloid. And which type? It is thin type. Okay, this is actually wrong. This is thin type. Okay, thin type, that is this one. Okay, so that's why when you see keloid, okay, keloid you would have seen in many people, it is very like soft. Okay, that is because there is no thick collagen, there is no type 1 collagen, there is type 3 collagen. So this is thin collagen. Okay, thin collagen. This is a slight mistake in the image. And second is this overgrowth of granulation tissue also can occur. Okay, and this is known as proud flesh. So keloid and proud flesh are both separate entities. Okay, they are not the same. So let's see, let's solve the question. Okay, then there is some clinical aspects. Diabetes slows down healing process. Steroids block collagen synthesis. Okay, that's why steroids also decrease healing. And third is vitamin C deficiency also causes weak collagen. That's why that also causes problem in healing. These are like core NEET PG questions. So collagen, which type of collagen is early collagen? Type 3, that is thin collagen, and type 1 is late, that is thick collagen. How much wound strength is restored by 3 months? That is 70 to 80% of wound healing is restored by 3 months. Dash is equal to excessive granulation tissue. See this image. What is excessive granulation tissue? See, this is granulation tissue. This is excessive colloid. So what is excessive granulation tissue? Excessive granulation tissue is proud flesh. And keloid shows which collagen excess? I said thin collagen. Okay, earlier collagen, the initial collagen, that was type 3. Which is a major fibrosis driver? This you will have to remember, TGF beta. Okay. Next, VEGF causes angiogenesis. Write down all this in your PDF. Okay, you will not forget these things. What deficiency impairs collagen? That is vitamin C. This is all you need to know about wound healing and repair. Next topic we are going is very important cell adaptation, that is hypertrophy and atrophy. You might think why I am still rolling in general pathology. That is because NEET PG pathology examiners itself are rolling in and around general pathology. If you see, 35 to 40% questions are asked just from general pathology. So that is the point of this revision series. Okay. So coming to cellular adaptation, very important to note 2 things: hypertrophy and atrophy. Many questions are being asked. Hypertrophy and atrophy, one thing you have to realize is total number of cells which are there, that is constant only. It is just the size of the cells decrease or increase. So in hypertrophy, size of the cells increases, as seen in left ventricular hypertrophy, or in uterus during pregnancy, size of the cells increases. That's why it is hypertrophy. Similarly, which pathway is involved in hypertrophy? Just remember mTOR, nothing else. Okay, just mTOR pathway is involved. Similarly, in atrophy, which pathway is involved? Cells are like whichever is useful, no, all those are dying. So that is causing autophagy. Okay, cellular organelles are dying. Okay, not cells, cellular organelles. Okay, see here mitochondria are saying, no, mitochondria is releasing cells components that are causing the cells to shrink and die. Okay, so this is mediated by ubiquitin proteasome pathway. Okay, seen in brain atrophy. Okay, so what are the mechanism behind this? One is there will be some mechanical stretch receptor, like when you're doing exercise, or maybe you're doing maybe some hormonal factors are there. So these sensors are there. Okay, this causes activation of mTOR pathway. Okay, that is for hypertrophy, what we are calling. Okay, it causes ribosome assembly and increases protein synthesis, because of it the cell will grow in size. Similarly, for atrophy, there is decreased survival signals. Okay, and whenever there is disuse of any organ, let's say because of some denervation, like nerve has cut down, so the organ is not able to, the muscle is not able to do its function. So that is known as disuse atrophy. It activates autophagy via ubiquitin proteasome pathway. See, when you see images, you never forget. You will definitely remember red. Red is for hypertrophy, and hypertrophy there is mTOR. Blue is for atrophy, and here you have ubiquitin proteasome. So that causes organelle recycling and then protein degradation. Remember, here cell is not dying. So most of the times these are reversible. Okay, like for example, if denervation is treated, then it is reversible. Similarly, if during exercise, okay, like left ventricular hypertrophy occurs in athletes and all, okay, so that can be reversible if causes addressed early. What are the examples? So physiological examples of hypertrophy is uterine like enlargement during pregnancy, and pathological is LVH, left ventricular hypertrophy. Okay, similarly, pathological cause of like atrophy is, what is this? This is not skeletal muscle hypertrophy. This is muscular dystrophy. Okay, muscular dystrophy, there is decrease in the size of the muscles. So now, what is hyperplasia? Hyperplasia is increase in number of cells. Okay, there is cell division, but in hypertrophy there is no cell division. Okay, that is important. No cell division in hypertrophy. It is only the cells that are getting bigger in size. Similarly, in atrophy there is no cell death. Okay, if cell death occurs, then it is hypoplasia. Okay, so let's solve the MCQs. Okay, see, what is the mechanism of atrophy? Ubiquitin proteasome pathway. That is the mechanism. Okay. Physiological occurs in, hypertrophy occurs in uterine during pregnancy. Cell number remains same in hypertrophy, it remains same in atrophy also. Next, which pathway is involved in hypertrophy? mTOR pathway is involved. What is best marker of atrophy? It is autophagy. There are a few important things also I want to focus you on. One is, whenever there is denervation atrophy, it is always rapid and it is severe. Second thing is, atrophy shows which type of pigment deposition. It is brown atrophy because of lipofuscin pigment deposition. Okay, so brown atrophy occurs in, lipofuscin pigment deposition occurs in atrophy. Okay, and yes, that's it. Now we'll go to next topic, that is calcification. One more important topic, very important, always one question will be there, that is calcification. So two types you know by now, that dystrophic and metastatic. Okay, so dystrophic is in the aging cells or damaged cells when calcium gets deposited. Okay, so that is dystrophic, especially in the heart. Second is metastatic, when bones only release calcium, that is calcium is only high. Okay, and I will never forget, calcium itself is high, that is metastatic. So dystrophic, like for example in atherosclerotic plaque, calcium gets deposited. Okay, or in the lungs, you can see, this lungs, there is some TB focus. Okay, their calcification occurs. This is dystrophic. Metastatic is where, like for example in kidney disease. Okay, in kidney disease there is a deposition of calcium crystals in the stomach, or in hyperparathyroidism there can be increased calcium. In bone resorption there can be increased calcium. So whenever hypercalcemia occurs, remember, whenever hypercalcemia occurs, it is metastatic, and in old damaged tissue, whenever calcium deposition occurs, it is dystrophic. Now, how to know whether calcium deposition is there or not? This is by using this specific stain known as one COSA stain. Remember this, one COSA stain. Now, how this happens? See, whenever there is cell injury, dead cells, calcium crystals come and they get deposited in the dead cells, like atherosclerotic plaque and old TB. This is dystrophic calcification. And when there is excess calcium, it gets deposited directly in the lungs, stomach and kidney. This is known as metastatic calcification. Now, in aging heart valve and in tumor, whichever tumor which is undergoing necrosis, if calcium gets deposited, okay, it can cause some clinical effects. Like for example, calcified mitral valve can cause valve stenosis, but these are reversible again. Okay, and again in in end-stage renal disease, you will see calcium crystal deposition under the skin that causes painful skin lesion, that is known as calciphylaxis. Okay, and in it can cause organ dysfunction also, but these are reversible if hypercalcium is corrected. Now one more thing is this dystrophic calcification occurring in tumors, for example in papillary tumors. Okay, that is papillary thyroid carcinoma, papillary serous carcinoma of ovary. So there you will find laminated bodies with calcium deposition. These are known as Sarcoma bodies. Remember, one thing which I told was which gets again repeated is VEGF causing angiogenesis, and second is this Sarcoma body which keeps on repeating. Okay, so you can fall in trap if you note that dystrophic doesn't has high calcium. Remember this. And second is Sarcoma is seen not only in papillary thyroid carcinoma, it is seen in many papillary carcinomas, and we'll see it in the coming classes. So damaged tissue causes dystrophic, high calcium causes metastatic, and laminated bodies are known as Sarcoma bodies. So with this we'll solve our fill in the blanks. So normal calcium, damaged tissues, dystrophic calcification. High serum calcium, normal tissue, metastatic. Atherosclerotic plaque, old TB lesions, dystrophic. Hyperparathyroidism, CKD, bone resorption, metastatic. Laminated calcification are known as, in the tumors are known as Sarcoma bodies. Very important. Which stain is used for calcium? 1-CoSA stain. Next, what is seen in end-stage renal disease? Calciphylaxis, okay, which are painful skin lesions. Okay, vitamin D toxicity causes metastatic calcification because it increases calcium. Sarcoma bodies are seen in papillary tumors. Okay, so I have made it very simple. Okay, we'll go to next topic, that is types of inflammation. Okay, so types of inflammation is very easy. We'll directly go towards, you go to the image. It is very simple. There's nothing to explain. These are various type of images. So acute acute inflammation, okay, it is mediated by neutrophils and it is rapid onset. Chronic is mediated by lymphocytes and macrophages. Okay, fibrin rich exudate, see here, fibrinous inflammation that is seen in pericarditis, fibrinous pericarditis. Okay, so there is fibrin deposition. Epithelioid and giant cells as in TB and sarcoid are seen in granuloma. Okay, rest of things you go through, it is simple only. Bread and butter pericarditis is seen in fibrinous pericarditis. This is a simple topic, that's why I think that doesn't need explanation. It is straightforward explanatory. So we'll go to next topic, that is types of necrosis. Okay, so necrosis, different types. Okay, one is coagulative necrosis. So you can see here, like we are seeing structure of heart. This is well defined. Okay, well defined. The structure is maintained. Okay, that is seen in coagulative. Most of necrosis are coagulative type of necrosis. Second is liquefactive, where content is liquefied. Remember, only brain is the example. Okay, only brain. That is only thing you need to remember. Caseous necrosis, it is always TB unless proved otherwise. The other example you can get is histoplasmosis. Okay. Next, fat necrosis occurs in pancreatitis, where because of leakage of this lipase enzyme, no, all these things get necrosed. Okay, so this is fat necrosis. Saponification occurs and release of fatty acids occur. Okay. Fifth is immune mediated necrosis, that is fibrinoid necrosis, where immune complex deposition, see, you can see immune complexes here, those deposition causes necrosis. So this is known as fibrinoid necrosis in vasculitis. And sixth is gangrene, where there is dry gangrene, mummified, and wet gangrene, where there is superimposed bacterial infection and all. So this is dry and wet gangrenous. Okay, so we'll fill in the blanks. Preserved outlines, ischemia, classic example. This is coagulative necrosis. Okay. Next, enzymatic digestion of brain. This is liquefactive necrosis. Next, cheese-like TB granulomas. This is always caseous. Next, lipase mediated in pancreatitis, this is fat necrosis. Immune complex mediated in vasculitis is fibrinoid necrosis. These are all one-liners for NEET PG. Next, ischemic mummified tissue is nothing but dry gangrene. Okay. One more important thing is gumma. What is gumma? Gumma is granulomatous ulcer, not ulcer, it is a granulomatous lesion seen in syphilis, in tertiary syphilis. Okay. So there is separate type of name for this necrosis, that is gummatous necrosis. Okay, it is firm rubbery like necrosis. It is not caseous necrosis. So if you mark caseous, you will be wrong. It is known as gummatous necrosis. Which necrosis is seen in malignant hypertension? This is fibrinoid necrosis. In malignant hypertension, we have fibrinoid, and in TB, in brain ischemia, it is always liquefactive. TB, we have caseous necrosis. Okay, yes, that's it. So we'll go to next topic, that is wound healing. We have already seen healing and repair. We'll see wound healing in specific. This topic, again, I would focus on things which are only important. One is, what are the stages of wound healing? One is inflammatory phase in the first 2 to 3 days, where there is inflammatory cells coming, everything is happening here. Second is proliferation, where there is angiogenesis, there is deposition of these cells. Okay, these are fibroblast cells. Okay, fibroblast, and slowly there is scar formation. And third, it is remodeling phase, where proper the wound scar formation takes place. Abnormal, I have already told, keloid and proud flesh. Okay, this is just repetition. So if there are fibroblasts, there are myofibroblasts. So these myofibroblasts are involved in wound contraction, which means once this scar tissue is deposited, then that scar tissue gets contracted. Okay, that scab gets contracted. That is because of this myofibroblast. Now, important thing here is to note what is primary intention and secondary intention. When it is a clean gaping, non-gaping wound, then it heals by primary intention. There is no scar formation. If it is a wide, contaminated and a big wound, then it requires secondary intention and scarring. So important things, which are the factors which delay in wound healing? One is diabetes, vitamin C deficiency, steroids and infection. So moving to the fill in the blanks, granulation tissue is dash plus angiogenesis. I told you fibroblast. So there should be fibrous scar formation, fibroblast with angiogenesis mediated by VEGF. Collagen is type 3 collagen first, that is thin collagen, followed by type 1, that is thick collagen. Dash in the clean edges and minimum scar is primary intention, and secondary intention is a large wound with more granulation. Keloid is excess of type 3, we have already discussed. What contracts wound? Myofibroblast. Myofibroblast contracts wound. Which deficiency delays epithelialization, not delays wound healing, delays epithelialization? This is zinc deficiency. Zinc is involved in epithelialization. Okay. Next, if angiogenesis is evident, then it is which phase? Then it is proliferative phase, that is second phase. Remember 3 phases. No? First is inflammatory phase. See here, inflammatory phase, proliferative phase and remodeling phase. If there is angiogenesis, then it is proliferative phase. Avoid dash during healthy healing phase. Avoid steroids, because steroids delay wound healing. Okay, so we'll go to next topic, that is pathophysiology of shock, and there are so many things to be discussed in this. Okay, so next important topic is shock. Okay, so you need to remember some important things about shock. What is shock? Shock is decreased tissue perfusion, which means your total blood coming to the tissues is decreased. So there are only 4 types of shock. Okay, this should be very clear. No other types of shock, only 4 types of shock. One is hypovolemic, cardiogenic, obstructive and distributive. Now notice this, I'll explain you whole concept. So this is the heart, these are the blood vessels, these are the capillaries, and this is the blood back to the heart. Okay, now what happens in hypovolemic shock? The blood that is circulating gets lost, like in trauma there is hemorrhagic shock or maybe diarrhea, fluid is lost. So effective circulating blood volume is decreased, so capillaries will also have less of blood. Okay, so what will happen? Eventually JVP also will decrease. So this is simple hypovolemic shock. Second is cardiogenic shock. Here the problem is heart. Okay, heart doesn't pump properly. As a result, this fluid doesn't get circulated. There is this pump failure. So now what happens is, because the pump is not, the fluid gets accumulated in the capillaries. That's why JVP will be high. Okay. Now next, coming to obstructive shock. Obstructive shock occurs in pulmonary embolism or pericardial tamponade. Okay, cardiac tamponade. Okay, cardiac tamponade. So what happens in this is, the heart is not able to pump because of an obstruction in the like around the heart or in the pulmonary vasculature. So now JVP will again be high, because there is something forcing the heart, blood doesn't come into the heart because there is some obstruction. Okay, so there is high JVP. Fourth type is distributive shock. So that is where you will be having 3 types of shock in distributive shock. This is very important because everyone gets it wrong. Distributive shock is when these blood vessels, so see, the problem with hypovolemic was the content inside these blood vessels. With cardiogenic shock, it was the pump. With obstructive shock, it was some obstruction. But with distributive, the whole capillaries, the whole capillaries and arteries, these have problem, and that happens because of 3 reasons. So distributive shock is of 3 types. One is septic shock, one is neurogenic shock, and third is anaphylactic shock. So simple thing, in all of this, what happens is the vessels are there, no, blood vessels, capillaries, they get dilated. Because of this dilation, even though the blood volume is the same inside, because of dilation, see, when you're using garden hose, okay, pump or like pipe, okay, if the pipe diameter is less, the flow decreases, right? There is no pressure. Only when the diameter decreases, only then the pressure increases. The same is for in cardiac output also. If the diameter of the blood vessels increase, that is, if vasodilation occurs, the pressure decreases. Okay, that's why blood pressure decreases, patient will go into shock. So the problem is with blood vessels in distributive shock. Now, what are the causes of shock? There is some insult, okay, because of which hemorrhage can occur, or some obstruction can occur, or vasodilation can occur because of sepsis, or it can occur because of anaphylaxis, or it can occur because of a neurogenic breakdown. Okay, there is something called as neurogenic shock also. Because of this, what happens is cardiac output decreases. Now, what happens is cardiac output is like your water that comes to your garden, okay, through the pipe. So cardiac output is dependent on two things. One is stroke volume, and second is based on heart rate. So now, what is cardiac output? Cardiac output is equal to stroke volume into heart rate. Okay. Now this stroke volume is nothing but it is, you can remember, it is like a output of the pipe, and heart rate is number of times your heart is beating. Okay. Now this stroke volume depends on three factors again. One is preload, afterload, okay, and peripheral vascular resistance or systemic vascular resistance. Okay. So will not go much into depth, but remember that this peripheral vascular resistance or systemic vascular resistance is nothing but the diameter of the blood vessels. Okay, if the diameter increases, peripheral vascular resistance has decreased. Okay, resistance has decreased. If the diameter decreases, resistance has increased. Only remember this much. Now what will happen is, because of this, now our body doesn't allow things to go haywire, right? If something goes wrong, it will try to correct it. So what happens is, when cardiac output decreases, our tissue, it gets less oxygen delivery, okay, because blood supply is less. So now what will happen is, there is inadequate tissue perfusion. Because of this, now the body will try to compensate it. So what are the compensatory responses? This is stage 1 of shock, which is compensatory shock, okay, which is reversible. Now what body will do is, I said you cardiac output is dependent on stroke volume and heart rate. So body will try to increase heart rate, that causes tachycardia. Second is, body will try to release those molecules which increase heart rate, that is adrenaline, that causes tachycardia. And it will also increase the pumping capacity of the heart, that is inotropy. Next is, body will try to decrease what? It will try to decrease increase peripheral vascular resistance. Now to increase peripheral vascular resistance, what you should do? You should constrict the pipe. So there is vasoconstriction. Okay, so vasoconstriction causes, because of which the hands and peripheries become cold. And fourth is, body will try to retain how much ever fluid is there. So fluid retention will happen. Okay. So now if with these the body can try to compensate, okay, or if the cause is addressed, if the mechanism, everything gets perfect, and like for example, diarrhea resolves, or maybe blood loss is prevented, so body will revert back to normal. But if this doesn't happen, then it will progress to next stage, that is stage of uncompensated shock, okay, or decompensated shock. Here what will happen is, tachycardia will increase, okay, catecholamine secretion will increase. Now what will happen is, even with this, blood supply is not maintained, so body will go into anaerobic mode of respiration. So ATP will decrease and lactate will start increase. Why? Because lactate doesn't need ATP. Okay, so directly glucose is converted into lactate, and what lactate will do is, increase lactate will happen in decompensated shock. Okay, so now vasoconstriction will, everything will start increasing. Okay, now what will happen is, finally it will lead to, if this is not addressed, it will lead to multi-organ dysfunction. Okay, we call it as MODS, and then it will lead to multi-organ failure and death. So these are the three phases of shock. That is, one is stage 1 uncompensated, decompensated, and irreversible or multi-organ dysfunction. Okay. This is, I have explained to you in simple terms. So what will happen is, normal aerobic will turn into anaerobic respiration during a shock. Now, which are the things that will help you? One is JVP. I told you how JVP is helpful. Skin temperature, shock will be peripherals will be cold during shock. And third is high lactate. So what is the treatment? Treatment is simple. You give fluid resuscitation. If there is blood loss, you give blood resuscitation. If it is septic shock, you give antibiotics. And whatever cause of the shock is there, you need to address it, especially in obstructive shock. Now let's solve MCQs, and there is one more concept known as warm shock. So what is warm shock? Normally in shock, what happens? I said you, because the body tries to increase peripheral vascular resistance, it will cause vasoconstriction. Now what will happen is, because of vasoconstriction, periphery should be cold. But what will happen in warm shock, that is septic shock, because of sepsis mediators, there are many inflammatory markers, cytokines. Because of that, what will happen is, there is no vasoconstriction, that causes vasodilation. Okay, vasodilation. And this will cause hands to be warm, peripheries are warm. Okay, this is known as warm shock. Okay, so we'll answer the MCQs. So cellular effect, it shifts to anaerobic metabolism. Okay, anaerobic metabolism. Next, blood loss or fluid loss along with decreased preload. Preload means total affecting circulating blood. This is seen in hypovolemic shock. Okay, this is the first type of shock. Pump failure, cardiac failure with increased left ventricular ejection end diastolic pressure. Okay, means ventricle is not able to push outward, because of which more blood is pulled down in the ventricle only, causes left ventricular failure. This is known as increased left ventricle ejection diastolic pressure. This is seen in cardiogenic shock. Okay, not ejection, end diastolic pressure. Okay, cardiogenic shock. Next, vasodilation occurs. Vasodilation, remember, vasodilation with decreased systemic vascular resistance and increased cardiac output. This occurs, decreased systemic vascular resistance, this occurs in distributed shock, especially septic shock. Next, cardiac tamponade and pulmonary embolism, obstructed blood flow, this is obstructive shock. So these are the 4 types of shock. Okay, septic shock is a component of distributive shock. Now, next, warm shock occurs early in sepsis. It is a type of septic shock. It is important in septic shock, first phase, that initial phase will be warm shock. Okay, later on it will turn into cold shock only. Okay, all these details I won't go into depth. Which shock presents with bradycardia? Very important. Bradycardia occurs in only one shock, that is neurogenic shock. Neurogenic shock causes bradycardia. Why? There is no time to explain. Anaphylaxis causes which type of shock? Anaphylaxis causes distributive shock. Okay. Next, decreased systemic vascular resistance with warm limbs, that is, okay, so decreased systemic vascular resistance with warm limbs is nothing but warm shock or septic shock. Okay, which shock causes which shock causes is seen in tamponade and pericardial effusion? It is obstructive shock. Now, high dash is seen in tissue perfusion, high lactate. Okay, this occurs in second stage of shock. If low JVP and there is hypotension with low JVP, there is shock with low JVP, we'll think mainly of hypovolemic shock, because effective circulatory volume is decreased. Dash needs early antibiotics, septic shock needs early antibiotics. See, many type of questions can be asked on shock, not only from pathology, it can be asked from medicine, pediatrics, surgery, any topic it can be asked. So you should be well versed with shock, and I think I have tried to cover most of the important content. Next we'll go to hemato-oncology part. Okay. So in hemato-oncology, one of the most important topic is CML, okay, chronic myeloid leukemia. Leukemia basics will come later on. Okay, so chronic myeloid leukemia, one important thing you should remember is CML means always Philadelphia chromosome, and Philadelphia chromosome is nothing but translocation 922. Okay, 922. So how to remember this? See, this is chromosome number 9, where ABL part is there. Okay, this ABL part has tyrosine kinase enzyme, and this 22 is BCR part. So that's why BCR ABL. BCR is like an on switch. So when that on switch gets on tyrosine kinase is involved in proliferation of cells. Okay, so there is on switch continuously. That's why there is a continuous activation of cells that leads to myeloid series of cells are propagating at unlimited pace. Okay, that causes CML. Now, which investigation is used? FISH probe, and this is an important question. Okay, so one marker is on BCR and one marker is on ABL. Okay, so that's why you will get red and green markers. Okay, so now what will happen is, first genetic event is chromosome 9 and 22. Which type of translocation? This is reciprocal translocation. Okay, reciprocal translocation. Okay, and then it causes Philadelphia chromosome. This is the fused Philadelphia chromosome, and then BCR and ABL gene are fused. Now what will happen is, second step, tyrosine kinase. Okay, tyrosine kinase causes proliferation of lymphocytes and other leukocytes. So that activity will increase. So this is nothing but tyrosine kinase. Now what will happen is myeloproliferation, bone marrow proliferation will happen. As a result, all type of myeloid lineage cells are increased. So there is leukocytosis, high WBCs. Now what are the clinical manifestation? There will be fatigue, because now WBCs are increasing. So RBCs and all will come down. Okay, so there is fatigue. Second is splenomegaly splenomegaly will be there. Splenomegaly will be because of direct sequestration, direct leukemic infiltration, and because there will be higher extravascular hematopoiesis also extramedullary. That's why also splenomegaly will occur. Now, basophilia will occur. This is very important because in basophilia, why it occurs is because when tyrosine kinase is increased, it increases IL-3, okay, and this IL-3 selectively increases basophils. So whenever there is basophilia in the question, always remember CML, okay. And fourth is this lab score. What is this lab score? Lab score is nothing but leukocyte alkaline phosphatase, okay, leukocyte alkaline phosphatase. Normally this is secreted by the neutrophils, but since here there are abnormal neutrophils, okay, see these neutrophils, whatever they are producing, they are leukocyte, they are abnormal. So this because abnormal cells secrete don't secrete right type of leukocyte alkaline phosphatase enzyme. That's why LAP levels will decrease, okay. So these are the four main points that you need to remember. Now you see this blood smear finding. What you will find? You will find many basophils. You will find high WBC cell count. Now important is, what is this left shift? What is this left shift? See, when WBCs are maturing, this is the pluripotent cells, then comes immature cells, then comes the mature cells, okay. So now what will happen? Left shift means there are more of immature cells. So more of immature cells is known as left shift, okay. So what is the treatment? Treatment is simple. We give tyrosine kinase inhibitors, and the prototype drug is imatinib, okay. What it does is it blocks tyrosine kinase, and hence there is no proliferation of cells. Now how to monitor treatment? We see this BCR ABL levels. We do PCR, that is we do genetic test and see how much is the level, okay. That is how we monitor. So tyrosine kinase therapy is the first line therapy. Now which are the other type of tyrosine kinase inhibitors? One I told you, imatinib, okay. So all TINIBs, TINIB, TINIBs, imatinib, dasatinib, okay. Then comes nilotinib, okay. Now what will happen is there will be resistance to these first line. These are first line tyrosine kinase inhibitors, and that resistance is seen in this T3151 mutation. T3151 mutation, okay. So in this case we give second generation, that is ponatinib. Remember this is repeatedly asked. Ponatinib is the drug of choice for second resistance cases of like CML, okay. And the transplant option is that is stem cell transplant. So there are three phases in CML. That is, one is chronic phase, which means slowly the cells are dividing. There are only few blast cells, but once it goes into accelerated phase, then worsening of symptoms start, and then when there is many blast cells, then it causes blast crisis, and it looks like acute lymphoblastic leukemia, okay, ALL, okay. So one differential diagnosis of CML which is asked in your question says ALL, and how to differentiate it we'll see in the fill in the blanks part, okay. So which mutation? BCR ABL mutation, causing translocation of 922. Next, very high WBC with the left shift occurs, okay. Basophil, what is hallmark? Basophilia is the hallmark. Which score is low in CML? Lab score, that is leukocyte alkaline phosphatase score is low. Treatment first line is imatinib, okay, imatinib, dasatinib, and nilotinib. Second line, what is second line? Second line is ponatinib, okay, ponatinib. Monitoring is with the BCR ABL PCR levels, okay, PCR, polymerase chain reaction levels, okay. Blast crisis resembles ALL, okay. Now T9022 also occurs occasionally in ALL, so it is very important to differentiate with ALL, okay. TKI, that is tyrosine kinase inhibitor resistance, is linked to T3151 mutation, okay. Next, if LAP is high, then it is ALL. Why? Because in ALL normal neutrophils are only secreted at higher rate. That's why in CML LAP is low, in ALL LAP is high. See, these are the subtle differentiating points in your MCQs. That's why you are not able to rule out two options. Next, if blast percentage increases, always think of ALL. Always think of third phase, okay. Third phase of CML, or it can be ALL also, okay. Okay. So next we'll go to next topic, that is hematopoiesis. We'll come to the basics of hemato-oncology. So coming to hematopoiesis, a very important physiology topic. See, basic only you need to understand. One is pluripotent stem cell is there. That will progress to either myeloid series or it will go to lymphoid series. In myeloid series, you have RBCs, platelets, neutrophil, eosinophil, and basophil. Okay, remember this much. What is the precursors of all this? For RBCs, it is erythroblast, proerythroblast. For platelet, it is megakaryoblast. For all these granulocytes, it is myeloblast, okay? And then there is a monoblast also. On lymphoid side, you have just B cell, T cell and NK cell, okay? More importance is given for this myeloblast, okay? Because ALL actually arises from this part only, okay? So important question other than this is fetal and adult sites of hematopoiesis. So in fetal, first 2 months always it is yolk sac. This will be asked as a match the following question, okay? Like first yolk sac will come, then comes liver, then comes spleen, okay, then comes bone marrow, okay? From fourth month onwards is bone marrow. In adults, all except question will come. Vertebra is involved, sternum is involved, pelvis, that is axial skeleton is involved, and long bones are involved, okay? Where you will get wrong is, one is you will think erythropoietin is secreted from liver. No, erythropoietin is secreted by the kidney, but thrombopoietin for platelets, that is secreted by the liver, okay? And increased reticulocyte means there is increased erythropoiesis. Whenever there is increased reticulocyte means more blood cells are being produced. If less reticulocyte means blood is not, RBCs are not produced in that rate, okay? So whenever there is pancytopenia, you will always see bone marrow, whether the problem is with bone marrow production or whether there is with increased destruction. If there is increased destruction, then bone marrow, there will be hypercellularity, means more number of erythrocyte precursors will be there, but they are getting destroyed, okay? So that is the first step in checking when there is pancytopenia. Now kidney produces erythropoietin, liver produces thrombopoietin, okay? That thing you have to remember. And for neutrophils, what is the trigger? It is GM-CSF, okay? That is granulocyte stimulating factor, okay? Then chemotherapy suppresses bone marrow, okay? So bone marrow biopsy will help in guiding that, okay? And this is the image showing a supravital staining of reticulocytes, okay? So we'll answer the questions quickly. That is thrombopoiesis, thrombopoietin is produced by the liver. Granulopoiesis is stimulated by GM-CSF, okay? And DASH regulates erythroid maturation. Which molecule? Actually, it is GATA molecule, okay? This was asked once in the exam. And which is essential for lymphoid lineage? For lymphoid lineage, what is essential is IL-7. So remember, where was IL-6? IL-6 was involved in CRP, okay? IL-8, where was IL-8 involved? IL-8 was a chemotactic agent. Remember, which were the 5 chemotactic agents? C5A3, C5A and LTB4, okay? So this is how you interconnect, okay? You try to recall things, okay? If there is hepatosplenomegaly, you will think of extramedullary hematopoiesis, okay? That is anemia with hepatosplenomegaly, okay? Okay, so we'll go to the next topic, that is hemophilia, okay? Hemophilia, a star question is regarding genetics, because most of you think it is autosomal recessive. It is not. Remember the dynasty of kings which got terminated because of hemophilia, because all their males were, most of the males were affected with this hemophilia. So it is X-linked recessive. There are very few diseases with X-linked recessive, and hemophilia is one of them. So hemophilia can be because of factor 8 deficient, that is hemophilia A, 9 is hemophilia B, and hemophilia C is factor 11, okay? So what happens in hemophilia is, because there is lack of these clotting factors, first stage is injury and bleeding. Most common is bleeding into the joint, that is known as hemarthrosis, okay? And it can also cause bleeding into the muscles or joints also. So next we do lab workup, okay? In that, what is increased? Now everyone has a confusion whether it is PT or APTT, okay? Remember this, PT is for extrinsic. For example, how to remember this? PT means, okay, when you're going, you have PT period, right? Physical training, that is in your schools you had PT period. At that time you used to go outside of the ground. You go to the ground and then you do exercise. No, you don't do inside, okay? You go outside and play. So that's why PT means extrinsic, APTT means intrinsic, okay? This is how you remember it, okay? So what happens in hemophilia is intrinsic pathway is affected. Factor 8 is coming under intrinsic pathway. So you'll note that PT time is normal, but here extended time of APTT. If you have good photogenic memory, you can remember it like this also. APTT timing is increased, okay? And next what you do is you do a mixing study. Now what is mixing study? There is something called as a factor 8 inhibitor. So what is factor 8 inhibitor? Factor 8 inhibitor means when a patient is given factor 8, okay, what is the treatment for hemophilia is whatever factor is lost, that you are giving it back, okay? Now for this factor 8, there are some antibodies which will cause its inhibition. So this factor 8 antibody is there, not to differentiate this factor 8 inhibitors and to differentiate between factor 8 deficiency, we use this mixing study. So here what we do is we add patient's plasma to normal plasma and then we mix it. So Suppose patient's plasma has hemophilia, then factor 8 is not there. Okay, factor 8 is not there. So in this case, what happens? Normal plasma will give factor 8 and this sample will not coagulate. Sorry, this sample will coagulate. Okay, that means the patient has hemophilia. Okay. Now what happens is if the this one has patient's plasma has factor 8 inhibitor. Now from this anyway factor 8 inhibition has happened. From this also it will cause factor 8 inhibition, so it will not coagulate. Okay, so this is used to differentiate whether patient has factor 8 deficiency or whether factor 8 inhibitors are present. So next we'll see what are the levels of factor 8 and 9. See this, factor 8 levels are decreased or factor 9 levels will be decreased. Any one of them will be decreased. Now what is the treatment? Treatment is simple. One is you give factor deficiency, you correct it. Okay, and second, this is factor 8 or factor 9 you will give. And second, in some cases, mild cases, you give desmopressin. Remember, desmopressin will give in one more form of disease, that is in 1 Willebrand's disease. Okay, so 1 Willebrand is the closest differential diagnosis of hemophilia. Okay, but in 1 Willebrand disease, the disease specifics are a little bit different. Okay, so prophylactic also we can give factor 8. Okay, factor 8 prophylaxis is also given, and you have to ask the child not to hurt himself more, not to fall down, not to sustain injuries, not to involve in high intensity sports activities. Okay, now what are the complications? Complication one is, I told you, against factor 8 there will be antibody development, that is known as inhibitors. Okay, for this inhibitors, now what will you do? There is no use of giving factor 8 because anyways factor 8 will even if you give factor 8, there are antibodies, so it will neutralize it. So you have to give something which bypasses this factor 8, because you remember in intrinsic pathway, first it starts with the factor 9 11. Okay, then 11A becomes 9A. Okay, 9 becomes then 8. Okay, so you want something which directly surpasses from like 11 which directly passes between 9 and 10. Okay, so this is 9. Okay, 9 and 10. And what is that? That factor is known as emicizumab. We are saying 9 and 10. There is a direct connection without going to it. This is emicizumab. Now, how to remember this? Actually, I have a junior. Okay, I had a junior in my MD whose name was Emiki. Okay, his name was Emiki. So I remember his this drug by his name, that is emicizumab. Okay, and this is for hemophilia. Okay, so that is the use of emicizumab. Okay. Now, what are the clinical signs? Hemarthrosis, muscle bruising, and target joint. What is target joint? If a joint gets repeatedly, there is bleeding because of trauma, and this hemarthrosis keeps on going, then it is called as target joint. Okay. Now, hemarthrosis, your intramuscular injection, IM injections are contraindicated because it can cause intramuscular bleeding. Okay. So hemophilia C is factor 11. Okay, emicizumab is a bridge between F9, factor 9 and factor 10. Okay, and target joint I have already explained. So let's answer the questions. Desmopressin is useful in mild cases of hemophilia. Okay, and it is useful in 1 Willebrand's disease, which is basically a separate entity. Dash is used in inhibitor positive. This one we use emicizumab. Okay. Target joints are the joints that bleed repeatedly, recurrent bleeding. Mixing steady correction deficiency. Okay, mixing correction. Okay, this is not this. Okay, what is the classic sign of hemophilia? That is hemarthrosis. Okay. Okay. So we'll move on to the next topic, that is hereditary spherocytosis. Okay, this topic can be asked in pediatrics also, in pathos and medicine also. So basically the defect is in the RBC cytoskeleton. Okay, so the spectrin and anchorin are the reason why RBC structure is maintained like this. Okay, it is biconcave structure. But the moment these anchorin and spectrum are lost, spectrin, so that time this becomes a spherical shape. Okay, now this spherical shape has less of a fragility, that is, it can't expand easily. Okay. So all the symptoms are based on that only. See, spectrin anchorin network is lost. Now what happens is surface area of this RBC is greater, but surface area here is less. Now what happens is when this RBC passes through the splenic vessel, that is known as splenic cords, this RBC, normal RBC can compress and go, but this doesn't compress. So it gets trapped, and then this gets engulfed by macrophages in the spleen, and then it undergoes extravascular hemolysis. Okay, because of which we'll have anemia, we'll have jaundice, we'll have splenomegaly also, because spleen is having all this graveyard of RBCs, and then because of this there will be pigmented gallstones. Remember, pigmented gallstones, the major cause is hereditary spherocytosis. So mainly treatment part will be doing splenectomy, because that is enlarged, then that is causing more hemolysis. We'll be giving vaccination before doing splenectomy. Which are the organisms against which we'll vaccinate? One is pneumococcus. What is pneumococcus? Pneumococcus is nothing but Streptococcus pneumoniae. Second is meningococcus, which is nothing but Neisseria meningitidis, and then we have Haemophilus influenza. Okay, these three capsulated organisms will vaccinate. Okay, now I'll go into some theory concepts. That is, for example, what happens in hereditary spherocytosis? There is increased destruction of RBCs. As a result, what will happen to bone marrow? Inside bone marrow, RBC production will increase, right? So there is increased RBC production. So bone marrow is full of RBCs. Okay, so that means there is more demand. Like the RBCs are getting destroyed easily, so there is more demand. So more RBCs are into circulation. So what happens to reticulocytes? Reticulocytes will also increase. Why? Because reticulocytes are precursor of RBCs, right? So there is more production of RBCs, so reticulocyte will increase. Now, very important, your NEET PG question will be, in a patient with hereditary spherocytosis, reticulocyte is decreased and bone marrow shows decreased cellularity, means RBCs or erythrocyte precursors in bone marrow are decreased. So what will you think of? This is known as aplastic crisis, where because usually most of the cases that defect is because of parvovirus B19. Okay, this parvovirus B19 damages all the erythrocyte precursors, as a result of which bone marrow doesn't produce RBCs and patient suddenly goes into anemia. And when you see reticulocyte count, instead of being high, it becomes low. This is known as aplastic crisis. Okay, this is a very important question. Okay, so what is left? Yes, one more thing is osmotic fragility. Osmotic fragility means how much the RBCs can tolerate this one. Okay, that is NaCl concentration. So spirocytes fragility is increased, which means at a concentration when it comes less, like for example, we'll suspend RBCs first in 1% saline, then we'll decrease 0.9%, then we'll decrease to 0.5% saline and 0.3%. So normal RBCs, what will happen is it will come till here. Okay, but this spirocytes, what will happen is they are already round. Now it can't become more round, it will swell up and it will burst. So by the time it comes to 0.5%, all the cells of spirocytes are lysed. Okay, that's why there is increased fragility on osmotic fragility test. Second is what happens to MCHC. What is MCHC? It is a concentration of hemoglobin inside the RBC. So if the RBC decreases in surface area, what will happen is hemoglobin will remain the same. No, hemoglobin inside is the same. So this increases. So this concentration increases. So MCHC will increase. That is given here. And important thing is, whenever there is hemolysis, we do one important test, that is Coombs test. Because Coombs test is useful when you suspect hemolysis because of antibodies, and this is known as autoimmune hemolytic anemia. Okay, in this test, Coombs test will be positive in this case. But in hereditary spherocytosis, since there are no antibodies involved, okay, this is just a genetic defect. That's why here Coombs test will be negative. Okay, so Coombs test will be negative. Now we'll go to the theory content. So what defect? Ankyrin spectrin defect. Okay, in some cases we'll also get band 3 defect. Okay, band 3 also, if it comes, you can answer it. Inheritance is autosomal dominant, very important, autosomal dominant. Okay, next, what happens to MCHC? MCHC is increased. Gallstones, pigmentary gallstones are present in chronic hemolysis because of hereditary spherocytosis. Aplastic crisis is because of parvovirus B19, and in this case reticulocytes will decrease. Okay, decrease. Which is the most sensitive test for hereditary spherocytosis? If it is asked, it is something known as eosin 5 malamide. Okay, just by heart this thing, I can't make you remember this. Eosin 5 malamide. What is the definitive treatment? Splenectomy. There is nothing else, splenectomy. And why do we give folate supplementation? Because when RBC turnover rate is so high, no, there is so much erythropoiesis, RBCs require folate to reproduce. Okay, that's why we give folate supplementation. The next topic is a very important topic, that is Hodgkin's lymphoma, where most of the questions are asked and many of you get it wrong, and I'll make sure that you don't make any mistakes. Okay, so there is only one thing you need to remember regarding Hodgkin's lymphoma, that is 15 and 30. Remember this number. Okay, because this is the number. If this CD 15 and 30 are positive, then it becomes RS cell, that is Reed-Sternberg cell. So Reed-Sternberg cell has only two properties, that is 15 and 30 positivity. Okay, based on this, it is divided into classical and non-classical Hodgkin's lymphoma. Okay, so what is classical? Classical is nothing but RS cell, that is Reed-Sternberg cell, has 15, 30 positivity. Okay, 15, 30 positivity is RS cell. Okay, 30. And what is non-classical? Non-classical, we have only one variant, which is CD20 positive, and that is known as nodular. Okay, nodular lymphocyte predominant Hodgkin's lymphoma, NLPHL. And remember, if anyone asks a question, which is the best type of Hodgkin's lymphoma, which has best prognosis, in which cure rate is good, it is non-classical Hodgkin's lymphoma, that is nodular lymphocyte predominant Hodgkin's lymphoma, has the best prognosis. So if you get this tumor, you are definitely cured because it is CD20 positive. Now, which are the other 4 types of classical Hodgkin's lymphoma? One is nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted. Now, if I ask you which type of Hodgkin lymphoma, if you get, you will be cured, that is nodular sclerosis. This has good prognosis among classical types, and lymphocyte depleted is the worst one. Okay, lymphocyte depleted is the worst one. Okay, no one wants to get it. Now, very important trap where students fell is contiguous and non-contiguous spread. What is contiguous? Contiguous means suppose one lymph node is involved. Okay, from this drainage happens into next lymph node, right? So contiguous means from this lymph node metastasis is spread to this lymph node. Then and along with that next means it is continuous type of lymph node spreading. This is seen in HL, that is Hodgkin's lymphoma. Non-contiguous, okay, non-contiguous is seen in non-Hodgkin's lymphoma. So non for non, okay. Non for non, N for N. Okay. Now, next, whenever there are B symptoms in Hodgkin's lymphoma, what are B symptoms? See this image: temperature increase, evening temperature, forehead sweating, okay, sweating, and then weight loss. These 3 are B symptoms. If this is there, then it is advanced stage already. Okay, so prognosis becomes poor. So what is CD20? CD20 is not classical Hodgkin's lymphoma. This is nodular lymphocyte predominant Hodgkin's lymphoma. Okay. Next, CD20 is not NHL. It is nodular predominant this one in Hodgkin's lymphoma. Okay. Now, how the progression happens? Normal B cell will have CD20 positivity. Okay. Now with RS cell, what happens is Rich-Sternberg cell 15 and 30 positive will happen because of Epstein-Barr virus. So Epstein-Barr virus is involved in pathology behind Hodgkin's lymphoma. Now primary lymph node, there will be contiguous spread to the nearby lymph node, and then it will result in cervical lymphadenopathy when a group of lymph nodes are involved. Okay. So these are the B symptoms. Remember, Hodgkin's lymphoma doesn't only present with cervical lymphadenopathy, it also presents with mediastinal mass. So any mediastinal mass, it is given here, any mediastinal mass in a young female, always mark the answer nodular sclerosis, and it has got a very good prognosis. Also, alcohol induced lymph node pain is always related to Hodgkin's lymphoma. And what is the easiest diagnosis, the earliest diagnosis, the most sensitive diagnostic marker for Hodgkin's lymphoma diagnostic modality? It is nothing but PET-CT. PET-CT is the most sensitive investigation. Okay, so what else can you do? You can do lymph node biopsy, and in biopsy you can see Rich-Sternberg cell. You will do PET-CT and you will see staging. ESR will be high. Okay, ESR will be very high, and eosinophilia also can be seen. These are the MCQ keywords which I have changed into images. Okay, so most common type among all classical lymphoma is nodular sclerosis. It also has the good prognosis among all Hodgkin's lymphoma, and lymphocyte depleted has a worst prognosis. Okay, now what is ABVD regimen? ABVD is adriamycin. Okay, adriamycin. B is for bleomycin, adriamycin, bleomycin. V is not vincristine, it is vinblastine. Everyone gets wrong here, and MCQ sector will also give you vincristine in the option. And D is in for dacarbazine. Dacarbazine. Okay. Adriamycin, another name is doxorubicin, so don't get confused here. Okay, this is doxorubicin. So there is prognosis is very good in Hodgkin's lymphoma. In some cases where radiotherapy is given, there is risk for a secondary malignancy. Okay, so I think I have explained everything from the image. So let's solve questions. So Rich-Sternberg cell, which positivity? CD15 positive and CD30 positivity. This is the only thing you need to remember. In non-classical type, that is nodular lymphocyte predominant Hodgkin's lymphoma, it is CD20 positive but 15 negative and 30 negative. Okay. Next, subtype, which is the most common? Nodular sclerosis is the most common type. Treatment, which treatment we give? ABVD for Hodgkin's lymphoma. Which type has worst prognosis? Lymphocyte depleted has a worst prognosis. Okay, and if mediastinal mass in young female, always think of nodular sclerosis. Okay, that's it. Okay, so next we'll go for leukemia classification. This is a very important topic but very difficult to memorize. I'll make sure by the end of next 10 minutes you don't forget things. Okay, so first thing is leukemia. What is leukemia? Leukemia is proliferation of blast cells. Okay, remember, what is blast? Blast can be myeloblast or it can be lymphoblast. If you go to hematopoiesis, that is chapter number 13, you will realize that there is something called as myeloid series and there is something called as a lymphoid series. Okay, So in lymphoid series, we have two types of cells. That is, one is T cell and another is B cell. In myeloid series, we have neutrophils, we have eosinophils, we have basophils, we have monocytes, and along with this, we have erythrocytes also, and we have platelets also. So all these come under myeloid series. Okay. So now leukemia. What is leukemia? Leukemia is specific for all these lymphocytes. That is leukocytes. Sorry, not lymphocytes, leukocytes. So now it can be acute leukemia or it can be chronic leukemia, any one out of this. Now acute has acute proliferation of myeloid series, or it can be acute proliferation of lymphoid series. Now which is bad in this? AML is bad, ALL is good. Now this ALL can again be B cell acute lymphoblastic leukemia, or it can be T cell acute lymphoblastic leukemia. Myeloid is only acute myeloid leukemia. There is one subtype in this which is important for us, that is acute promyelocytic leukemia. Acute promyelocytic leukemia. There are few important things you need to remember. Not everything is important. One is all rods are seen in AML. Next, translocation 15-17 and ETRA therapy, that is useful in APML, because APML is such a devastating that within like 1 or 2 weeks child will die. It is mainly seen in children. I had a patient during my MD residency, a small boy around 10 years. He was all right, fine. 2 weeks, since 2 weeks he had petechia and anemia. And then he was diagnosed, he was found to have APML. Within 1 week he developed DIC and he had brain bleed. And then he passed away in the ICU after 1 week. So it is that devastating, and treatment also requires very aggression. So there is only one treatment for this, one very important treatment, that is ETRA. What is ETRA? ETRA is all trans retinoic acid. And our hemat-oncologist, she was so adamant to get this ETRA quickly, because the faster anyone gets ETRA, the better will be the prognosis. So this you need to remember about APML. Now ALL will go again in depth. So ALL has this TDT positivity. TDT is an enzyme which is expressed. We'll go in the next slide. It is especially seen in children, and there are two types. One is BALL, which is common in smaller children, and TALL, which is common in adolescents. And for ALL, CNS and testis spread is very common. Next, what about chronic leukemia? Chronic leukemia is in majorly in elderly population. So it can be CML, which we have already discussed, BCR-ABL, Philadelphia, high WBC, low LAP. We have not discussed CLL, that is chronic lymphoid leukemia, where we see it in elderly who present with chronic lymphadenopathy. Along with that, there can be autoimmune hemolysis also. Remember this term, autoimmune hemolysis. And these have typical smudge cell appearance. So these are the microscopic images. One is OR rod and second is smudge cell. So I have already told CLL is slow growing tumor. This smudge cells, elderly, slow growing. And ETRA is exactly opposite. APML, it requires quick. Everything should be quick. If OR rod is there in the question, don't think anything else. It is AML, acute myeloid leukemia. If TDT is positive, always it is acute lymphoblastic leukemia. And if very, very high WBC is there, always remember at the back of the head in a chronic elderly patient, it could be chronic myeloid leukemia. You have to see for Philadelphia chromosome. Now, any leukemia comes to you, first you will assess symptoms, then you will see microscopy, you will see for blast cells in the microscopy. Then what you do is you identify which are the type of cells that are present, that is known as CD markers. And this you will get to know through flow cytometry. So you are seeing this machine, right? This machine identifies which type of cells are there in your blood. Next, cytogenetics, you see what is the haplotyping, which type of karyotyping is there, and which type of diploidy, which mutations are there. All this you see in cytogenetics. Next is subtype confirmation. Exact you get to know which type of tumor it is, and not tumor, sorry, which type of leukemia it is, and then you give targeted therapy. So this is the basic approach for leukemia. Now we'll go into the most difficult topic for a NEET PG aspirant, that is CD markers. CD markers. How to remember CD markers? So I'll tell you how to identify CD markers. First you take a bone marrow sample. This you should be clear. It should be bone marrow sample, or it can be peripheral blood sample also. Next you do flow cytometry analysis. This is the mission. Now mission will identify your separate cell, because cells won't tell the pathologist that I am myeloid type of cell, I am lymphocyte. There are some markers among the cells which helps to differentiate. So there are two types of lineages. One is myeloid lineage, another is lymphoid lineage. Now we'll see in myeloid lineage. So myeloid lineage, research, remember, for every cell there is one stem cell, right? And this stem cell, there is a pan stem cell marker. For every stem cell, one CD marker is common, that is CD34. So everything, every cell of hematology begins from 34 number. Okay, so 34 is the beginning of everything, that is CD34 is the marker for stem cell. Only remember this much. Next, coming to what does stem cell in myeloid series mature into? It matures, I told you, it matures into granulocytes. What are the granulocytes? They are neutrophils, eosinophils and basophils and monocytes. Okay, so what are these pan myeloid which are common in everything? Remember, 3, everything is in 3. Okay, 33, 13. Okay, there is 11B and 1B also, one extra alphabet. Okay, so 15 is 1 plus 5 is 6, which is a multiple of 3. So 33, 13, 11B and 15. All these are pan myeloid markers. Okay, this is common for all myeloid cells. Now, what is the specific? This you have to remember. Okay, if MPO is asked, MPO is the most important marker for myeloid series. MPO, myeloperoxidase. If MPO is there, it is acute myeloid leukemia, AML. Okay, next, megakaryocyte for platelet, 41 and 61. I don't know how you remember this, but after seeing this image for much long duration of time, you might remember this. Megakaryocyte, that is platelet, is 41 and 61. And for erythroblasts, okay, erythroid series, it is CD71 and glycophorin A. Glycophorin A you might remember. CD71 I don't expect you to remember. Okay, so now close your eyes and tell me which is the pan stem cell marker. It is CD34. Which are the pan myeloid markers? Everything 3. 33, yes, very good. Next one is 13, 1, 3, very good. Next one is 11B, 1B. And next is multiple of 3, that is 1 plus 5, that is 15. Okay. If I tell you MPO, it is myeloid series. If I tell you 41 and 61, it is platelet. If I tell you 71 and glycophorin A, it is RBC or erythroid series. So there should be no confusion regarding this now. Now we finished this myeloid series. Okay, now we'll go to lymphoid series. Now lymphoid series, there can be B cell, there can be T cell, there can be two aspects. Okay, so first we'll come to T cell. Remember, T is for all small children. Okay, T. Okay, T. So T cell, you will get everything like 2, 5, 7, 3, any single digit. Okay, single digit is T. Okay, this is single digit. Okay, so any single digit T comes, then it is T cell. Okay, so you just need to remember this 2, 3, 5, 7, that much only. Okay, nothing else you need to remember. Okay, next, TDT you already know. Okay, T cell, TDT, T, everything comes under T cell. Okay, now for B cell, that is B cell is also a lymphoblast, right? So here everything is for an adolescent. Okay, so adolescents, they are like in 20s, right? So I'll give the mnemonic also. So here you remember 19, 20, 22, 22. Okay, so all these are pan B cell. Okay, now there is one important concept that you need to remember regarding T cell and B cell, that is this CD10. What is this CALA? What is this CALA? Okay, so CALA is nothing but common ALL antigen. Okay, so CALA means common ALL antigen. Okay, so here it is CD10 positive. I don't know how you remember, but this CALA has the best prognosis. It has the best prognosis among ALL. That's why CD10 will definitely come in your exam. Okay, so CD10 CALA means ALL. Okay, remember this much. Okay, now there are some important things I want you to know. So this is the mnemonic. Okay, so B cell looks like a B. Okay, B teens. Okay, that is adolescents. Okay, so 19, 20, 22 years, all are B cell, that is adolescents. Okay, there are two more, that is CD79A and PAX5. You can remember by the thing that EA means adolescent. Okay, EA means adolescent. Okay, now T cell, I told you everything will be in small letters, that is 3, single digit, 5, 7, everything will be like that. Even 10 also you can consider under T cell, you can consider under B cell also. Okay, next myeloid, I told everything is in 3, 13. Okay, MPO, all these are in myeloid series. Okay, and one more important thing is, what is this CD5? What is CD5? CD5, remember, it is something aberrant, which shouldn't be there. You remember, no? In T cell you had done 3, 5, 7. So this 5, no? This 5 is something aberrant. Okay, this aberrancy helps us to differentiate CLL from mantle cell lymphoma. Okay, from mantle cell lymphoma, this CD5 helps us to differentiate. Just remember these things. I bet you can answer almost every question asked in NEET PG. So let's fill in the blanks. Blast, how much? More than how much? More than 20% of the marrow blast cells, we call it as acute leukemia. Myeloid, all rods are seen in AML. TDT is seen in ALL. CLL, which type of cells are seen? Very good. Elderly lymphadenopathy, which type of cells are seen? Smudge cells are seen. AML, 15-17 translocation, which subtype? Very good. I said I gave an example of myself. Okay, yes, very good. APML, okay, which is very aggressive. APML therapy, what it is? I said what our hemat-oncologist had to buy immediately, told us to bring immediately, that is ETRA, all trans-retinoic acid. Which leukemia shows TRAP positivity? Okay, these are some rarely asked fact, that is hairy cell leukemia. Hairy cell leukemia shows TRAP positivity. APML, there is risk of DIC, so it no DIC. Okay, that is disseminated intravascular coagulation. BCR-ABL means which tumor? CML. Okay, and which may cause autoimmune hemolysis? Smudge cells. Remember, smudge cells, elderly, lymphadenopathy, slowly progressing. It is CLL. So I hope everything is clear. This 2 pages summarizes everything regarding leukemia and CD markers that you need to know. Next we will go to lymphoma classification. So now let's move into lymphoma. Okay, so just like in leukemia we had B cell ALL, CLL, B cell ALL and T cell ALL leukemias. Similarly in lymphoma also we have B cell and T cell. Okay, so basically lymphoma is of 2 types. One is Hodgkin's lymphoma and non-Hodgkin's lymphoma. In Hodgkin's lymphoma we had classical variety and non-classical. In non-Hodgkin's lymphoma we have B cell non-Hodgkin's lymphoma and T cell non-Hodgkin's lymphoma. Okay, so what are the B cell? There are 4 types of B cell non-Hodgkin's lymphoma, and this is again a very difficult task to make you memorize things. Okay, so we have one is follicular, second we have Burkitt's, third we have mantle cell, and fourth we have marginal zone. Okay, this is for B cell. For T cell, we have one is mycosis fungoides or Sézary syndrome, and second we have adult T cell leukemia. This is only things you need to remember. Okay. Now, how to remember? Say follicular and Burkitt will get confused. This is because one has T14-18 translocation, other has T8-14. See how close it is. Follicular 14-18, Burkitt 8-14. Okay, so it is very closely close this one. Okay, so how to remember these things? So the easiest way to remember is, remember that follicles are nothing but petals. Okay, remember like petals. Okay, so this is the flower and there are petals and there are total 18 petals. Okay, so whichever is 18 is follicular, whichever is 8 is Burkitt's. Okay, remember like that. So follicular lymphoma, basically this is the lymph node. Okay, so this is the follicular zone. Okay, this is the mantle zone, and the outermost zone is the marginal zone. I'll show in the next slide. Okay, what are the 3 types of zones? So we have follicular zone, we have a mantle zone, and then we have marginal zone. Okay, so what happens is in follicular lymphoma there is T14-18 translocation, 18. Remember 18 petals. Okay, 18 petals of the follicles, and there is, see, this also looks like a follicle, right? This looks like a petal. Okay, so remember 18. Okay, 14-18, and what is increased here is BCL2. Now remember, where had you heard BCL2? Remember now only. Where did you hear BCL2? BCL2. Where did you hear? BCL2 you had heard in apoptosis. Remember, the police of our apoptosis was BCL2. I said CL. CL is police. So BCL2 was preventing apoptosis. So here also same thing. It is preventing apoptosis. That's why there is proliferation of the cells. Okay, so BCL2 overexpression is related to follicular lymphoma. Next, coming to Burkitt's. 8-14, I told you 18 is for follicular, 8 is for Burkitt's. Here you have C-Mic translocation and you'll get starry sky pattern. I think everyone will remember this. Next, coming to mantle cell and marginal, both are M. Here also M. Mantle cell is in the mantle zone. See, this is the mantle zone, and marginal is in the marginal zone. So how to remember? Marginal, okay, margin, that is outside, okay, is related to malt lymphoma. Now what is malt related to? Malt is related to H. pylori. Okay, so whatever is this maltoma, everything that is related to marginal zone. Okay, and mantle zone, we have cyclin D1 overexpression. Okay, cyclin D1 overexpression is seen in mantle cell lymphoma. Next, coming to T cell, we have only 2 types. One is mycosis fungoides, that is over the skin there is fungus-like growth. Okay, so mycosis fungoides, and which is also known as Sézary syndrome. That is because of T cell infiltration, and these T cells are known as Sézary cells, which are modified. They have a cerebriform, means brain-like nucleus. See, this is brain-like nucleus. Okay, and one more, you have adult T cell leukemia, which you have to remember HTLV, that is human T cell lymphotropic virus. This virus association is there seen in adult T-cell leukemia. So this is the basic thing you need to remember. Now, whenever you are suspecting a non-Hodgkin's lymphoma, first you will do node biopsy. Remember node biopsy. Even in Hodgkin's lymphoma also you were doing node biopsy. Then you will do flow cytometry. Remember, no, I had told CD markers, so you will do flow cytometry. Then you will see in Hodgkin's lymphoma there will be 15-30 positivity. I said RSL, okay, and there will be contagious spread. In non-Hodgkin's lymphoma, you have to see whether it is B cell or T cell origin, and it will have non-contagious spread. Okay. So what is a clinical correlate? One is jaw mass. See, whatever you're saying, no, jaw mass, that is seen in endemic Burkitt. So what is endemic Burkitt? This is the form of Burkitt which is prevalent in Africa. In rest of the world, it is known as sporadic Burkitts. Okay, so endemic Burkitt, we see jaw mass. Now, most of the times NHL, especially follicular NHL is not very difficult to treat. It is it has indolent course. It responds good to therapy, but sometimes it can transform into aggressive non-Hodgkin's lymphoma, and that aggressive is known as DLBCL. That is diffuse large B cell lymphoma. This is difficult to treat. Okay, and for DLBCL treatment we use R-CHOP. Remember, the images are so vast and detailed in this that even the medication name is also given as R-CHOP, so that you don't forget. So where do you make mistakes? One is you think that NHL has contagious spread. No, it is non-contagious spread. Means one group of lymph node is involved, and next some other group of lymph node may be involved. Okay, because of metastasis. Next, aggressive follicular trap. Okay, that is follicular lymphoma is not aggressive. Remember that I said follicular lymphoma is not aggressive. The most aggressive is diffuse large B cell lymphoma. Cyclin D1 I said occurs in mantle cell lymphoma, not marginal cell lymphoma. Next. Starry sky is in Burkitt's, and cutaneous involvement is seen in T-cell lymphoma, that is Sézary syndrome. Now let's fill in the blanks. Which is the most aggressive? Rapid progressive is DLBCL. Follicular has which expression? Translocation 14, 18. Remember 18 petals. Okay, and what is increase in follicular? BCL2 expression is increased. Cyclin D1 is for mantle cell lymphoma. Burkitt says what is the translocation? 8-14 with C-Mic. Which zone maltoma emerges from? Marginal zone. Okay. Next, which Burkitt causes jaw mass? Endemic Burkitt. Adult T-cell lymphoma is linked to which virus? HTLV. T14-18. Tell me now. 14-18. So 18 petals. 18 petals is what? Follicular. C-Mic transformation is seen in, translocation is seen in Burkitt's lymphoma. MALT regresses with which treatment? It is associated with H. pylori treatment. And what is the treatment for DLBCL? Remember that name on the medicine. What is that? R-CHOP. Okay. So isn't it easy now to remember things when things are explained in visual manner? So yes, I think you would have remembered everything by now. Moving to next topic, that is Myelodysplastic Syndrome. One more very important topic. Questions are being asked, but students often confuse this with leukemia. That is Myelodysplastic Syndrome, where myelo means bone marrow. Bone marrow is causing immature, like dysplastic cells, which are not effective. Okay, so it is basically ineffective erythropoiesis. Okay, ineffective erythropoiesis. So what will happen is inside the bone marrow, cells produced are not good. That's why when the cells come out, they die early. Okay, that is the basically defect in this. It is mainly seen in elderly population only. So what will happen is there will be anemia, there will be neutropenia, there will be thrombocytopenia, because these cells are not produced properly. And in laboratory report, main focus should be focused for NEET PG is increased MCV. Now why MCV is increased? Because of ineffective erythropoiesis. Same thing happens in megaloblastic anemia also. So on peripheral smear, you will see dysplastic cells. Okay. So how do you proceed? You have cytopenias, okay, and then you do bone marrow exam. Bone marrow examination, you will find dysplastic cells. Okay, and then there is ineffective erythropoiesis also, morphology you'll see. Then you'll do genetic study, that is cytogenetic study. One important deletion, that is 5q, that is short arm of 5th chromosome, is involved in this. Okay, then you do risk scoring for this, that is known as IPSS-R risk scoring, and then you plan therapy. Okay, so what do you other features you see in this peripheral smear? That is, one is ringed sideroblast. Okay, ringed sideroblast, if you see any word in the exam, think of myelodysplastic syndrome. And another is pseudo Pelger-Huet neutrophil. Now, what is pseudo Pelger-Huet? For that, you should know what is Pelger-Huet neutrophil. Pelger-Huet neutrophil is a genetic condition, okay, not pseudo, okay, Pelger-Huet, where there are only 2 lobes in the neutrophil. There are no 4 or 5 lobes. There are only 2 lobes. This is genetic, but if it happens in acquired causes, then it is called as a pseudo. Okay, and one of the main causes MDS. Okay, so what is the treatment that you will give? Transfusions you will give, blood transfusion. Erythropoietin is useful, but you will have to see, just like thalassemia, there can be risk for iron overload. So there can be disease modifying agents also, hypomethylating agents. Hypomethylating agents like azacitidine and dacitabine. Okay, you don't have to remember this, just remember hypomethylating agents are used, and curative is only bone marrow transplant. Okay, so now very important genetic part. Why I said 5q deletion? Because if there is 5q deletion, we have a magic drug, that is lenalidomide. It selectively kills the cells which have this 5q mutation. Okay, and what are the other causes? There can be many causes. It can be idiopathic, it can be related to chemotherapy, or it is also related to benzene exposure. Okay, and very, very important, why are we studying MDS now? Is because MDS has increased risk of progression to AML. This is an important NEET PG question. Okay, so we'll solve the fill in the blanks. Which deletion lenalidomide is important? 5q deletion. Okay, next, what type of neutrophils are seen? Pseudo, Pelger, Hute neutrophils. Secondary MDS results from what exposure? Which chemical exposure? Benzene exposure. Risk stratification is with which scoring? IPSS-R scoring. 5q deletion, we have lenalidomide response. Okay, so that's it we want about MDS, and we'll go to next topic, that is non-Hodgkin's lymphoma. We'll go one step ahead. Okay. Okay, NHL only. This is like a revision part. So I told you I'll show you the zones in a lymph node. So this is the follicle zone. So this is the follicle zone. This is the mantle zone, and this is the marginal zone. Okay, so these three are the zones in this one. Okay, and the rest things I think are the same which we had discussed earlier, except that in CNS prophylaxis, which is needed in Burkitt lymphoma. This is a question that was asked, so I had to include it here. Okay, rest of the things I think everything has been discussed so far. Okay, so we'll solve fill in the blanks. Origin, what is the most dash is the most common origin. Most common origin of non-Hodgkin's lymphoma is B cell. I said no, B cell has 4 types: follicular, Burkitt's, mantle, and marginal zone. Okay, some are T cell, that is Sézary and T cell leukemia. Indolent, which is the indolent type of lymphoma? Indolent type of lymphoma is follicular lymphoma, which is indolent means slowly growing, not much dangerous. MALT is associated with the H. pylori. Now, which staging is used for NHL? It is Ann Arbor staging. Okay, so Ann Arbor staging is used for Hodgkin's lymphoma, but with the non-Hodgkin's lymphoma with Lugano modification. Okay, Lugano modification. If this word is there, then it is for NHL. For Hodgkin's lymphoma only, then we use Ann Arbor. Okay. Okay. Next, extranodal gastric mass. It is Maltoma. Cyclin D1 expression is mantle cell lymphoma. Okay, so we have finished non-Hodgkin's lymphoma. Next we'll go to plasma cell dyscrasias. Okay, next topic is a commonly asked question, but many people miss this because they think this is not a part of hematonco. That is plasma cell dyscrasia, and everyone thinks plasma cell dyscrasia is equal to multiple myeloma, but it is not, because multiple myeloma, plasma cell dyscrasia has a wide spectrum. Okay, and this spectrum includes 1, MGUS, second smoldering myeloma, and third is multiple myeloma. So basically you need to know what is the difference. Normal plasma cell produces antibodies, which everyone know. Now if this clone of plasma cell is less than 10%, okay, and these antibodies, what they do, they produce this M spike, okay, M spike on electrophoresis. Now if this less than 10% polyclonal cells are there, then there will be only small spike. Okay, there is a small M protein spike without any crab features. Okay, I'll tell what crab features are. Then it is MGUHs. Okay, less than 10% clonal cells, clonal plasma cells with a small M spike and no crab features. That is MGUS. If it is more than 10% clonal plasma cells along with medium M spike and no crab features, then it is smoldering myeloma. And what is multiple myeloma? More than 10 with a large M spike along with crab features. So what are crab features? Crab features means C is for calcium, that is hypercalcemia, R is for renal failure, that is karst nephropathy. Basically it is because of M protein excretion through the kidney tubules that karst block the kidney and tubules and they cause nephropathy. Okay. Next is low RBCs, that is anemia, and last is lytic bone lesions. Okay, punched out lytic bone lesion. These are Kraft features. So only if Kraft features are there, then the answer is multiple myeloma. Otherwise, you should say whether the clonal cells is more than 10% or less than 10% and answer accordingly. So this is the whole spectrum. Now, how do you diagnose? You do electrophoresis, and in electrophoresis you see M spike, whether it is small, medium, or whether it is large, and then you can see light chain Bence-Jones proteins in the urine also. Okay. Next, bone marrow biopsy, you will see polyclonal cells of plasma cells. Okay, and RBC stacks will be there. Okay, rouleau formation will be seen on microscopy. Also, there is a related complication. That is, one is amyloidosis. AL amyloidosis is seen in macroglossia. If the answer specifically demands you which type of macroglossia, there is macroglossia in multiple myeloma, then what type of amyloidosis are you thinking of, then it is AL amyloidosis, and this is karst nephropathy. Okay, so what is the management? Easy. There are only two drugs. One is proteasome inhibitor, that is bortezomib, starts with B. Okay, bortezomib, and other is lenalidomide. Remember where we used lenalidomide in last slide? We used it for MDS also. Okay, so lenalidomide and bortezomib. Okay, and along with that, to maintain your bone health, that is for preventing osteolytic lesions, we use bisphosphonates. Okay, and how do you monitor progression? Using serum free light chain assay. You monitor your monitor the treatment progression. Now let's answer the questions. See, Bence-Jones proteinuria, these are nothing but light chains. Okay, light chains of the antibodies that are excreted. Okay, Kraft features I have already told. Amyloidosis, dash type from light chains. Light chains are of which type? AL type of amyloidosis. Okay, MGHS is more less than 10%. Okay, less than 10% with no Kraft features. More than 10% with no Kraft features suggests smoldering myeloma. Treatment is bortezomib. Write it down. Write it down. Then only you will study. Why I have created fill in the blanks is so that you write it down and you study. Lenalidomide. Okay. Next, myeloma cells secrete which interleukin, that is IL-6. Okay, myeloma cells secrete IL-6. Next, which myeloma has higher progression risk? That is smoldering myeloma. Smoldering myeloma has highest risk to progression to multiple myeloma. Okay. Next, dash reduces skeletal events, bisphosphonates. Okay, bisphosphonates reduces skeletal events in multiple myeloma. If macroglossia is suspected, suspect AL amyloidosis. Rest of the things you learn it on your own. Okay. Going to the next topic, now we are coming into more of peripheral topic, that is basal cell carcinoma. We'll be going into carcinomas now because pathology is all about carcinoma only. Okay, next is basal cell carcinoma. Why is it called basal cell? That is because if you go to the histology, these are the basal layer of the epidermis. Okay, from here cells are arising. That's why it is basal cell carcinoma. So when you see on histology, this is known as peripheral palisading pattern. Palisading means it is arranged like a fence. You see, it is arranged neatly like a fence. Okay, this pattern is known as peripheral palisading pattern, typical of basal cell carcinoma. Now, what are the risk factors? One is fair skin, radiation exposure, and third is genetic. Okay, if you have congenital mutations in PTCH1 gene, that is patch 1. Now, how to remember? All these look like patches, no? These look like patches on the skin. So, patch 1 mutation. Then you have predisposition to multiple basal cell carcinoma, that is known as Gorlin syndrome. Okay, so Gorlin syndrome is nothing but multiple basal cell carcinoma. So, what actually causes basal cell carcinoma? UVB exposure. This is very important. UVB, not UVA, not UVC, not UVZ. Okay, causes DNA damage, and that leads to PTCH1 patch 1 mutation, which is mediated via hedgehog pathway. This causes uncontrolled growth of cells and it causes local invasion. Very important thing is this basal cell carcinoma doesn't show metastasis. It rarely shows metastasis. Okay, so if it shows metastasis, then that sentence is wrong in NEET PG. Okay, so with respect to squamous cell carcinoma is more like a plaque-like. Okay, it is superficial, but basal cell is like deep invasive type. Okay, next, when you see basal cell carcinoma from the peripheral aspect, see here, see it looks like from top it looks like a pearly papule with telangiectasia, but from the side it looks like this. Okay, these are pearly edges. Okay, so this is known as pearly edges, and this appearance looks like a rodent has eaten something from here, no? So that's why it is known as rodent ulcer. Okay, so there is one type of variant known as superficial basal cell carcinoma also, which looks like eczema. Okay, so this image can also be given to you, and main site of basal cell carcinoma is head and neck. Okay, so pearly papule and rolled border appearance. Okay, next, what is the treatment? Surgery is the treatment, and there is specific surgery known as Mohs surgery, which has less recurrence rate, and rest is radiotherapy, and you have imiquimod. Okay, imiquimod is a superficial topical antibody like tumor capability, which destroys atypical cells. Okay, and then UV protection is the mainstay of treatment. So let's answer the fill in the blanks. Mutation, patch 1 mutation. Okay, patch 1. Ulceration, that's why it's known as rolled edge. There are rolled edges, so it is known as rodent ulcer. Treatment, we have Mohs surgery. Okay, M-O-H, yes, Mohs surgery. Mo, right? M-O-H-S, yes. Next, basal cell nevus syndrome is known as Gorlin syndrome. Okay. Dash is for superficial lesions. Imiquimod is used for superficial lesions. Which nuclei are seen in BCC? Palisading nuclei. Okay, so I think everything is condensed in one image only. Okay, so you at last moment for NEET PG, just see the image and go. That's it. Your memory will be very good. Going to next, that is carcinogenesis. This is a simple topic. I included this because one or two questions can be asked. I'll tell which. Okay, so basically carcinogenesis is nothing but transformation into cancer cells. So what happens is initially there is some carcinogen exposure in a normal cell which causes some irreversible mutation. Then this cell gets the promoter signal, okay, second hit, and then this starts irreversible expansion into benign, and then progression occurs, then angiogenesis occurs, then it progresses into distant sites, and then it causes metastasis. So this is basic what everyone knows. Okay, so there are carcinogens specifically, like for example we have chemical carcinogens such as aflatoxin which is seen in mushrooms, which causes p53 mutation. There are also UVB. Just now we saw, like in basal cell carcinoma, UVB is a carcinogen. There are viral carcinogens also, HPV, EBV, HBV, HCV, HTLV1. Okay, we'll see all this in detail. Okay, and we have specific genes which are involved in carcinogens. One is oncogenes. These are gas pedal, like these are like accelerators, like in like car, when you sit in the car you have accelerator and you have a brake. Okay, so these are the genes which if went into overdrive mode, no, they will cause more cell multiplication. So these are three main genes, that is, one is KRAS, one is Mike, and HER2. Have you heard of Mike anywhere so far? Yes, you have heard it. It's in Burkitt's lymphoma. HER2, you know, it is in breast. Okay, and KRAS is in colon carcinoma, also in pancreatic carcinoma. Okay, we'll go through all this in depth, and there are some breaks. Okay, with these are actually tumor suppressor genes. So when there is break failure, that is break fail, then there will be uncontrolled mutations. Okay, so that is, one is TP53, which is involved in many mutations, and RB gene, which is involved in two mutations. One is linked to HPV, that is cervical cancer, and anogenital tumors also, and then one more is in retinoblastoma. Okay, so we'll see all this in depth. Okay, so these things I think you can learn. I don't have to go through. Oncogenes, KRAS, main important ones. Okay, KRAS is there, Mike gene is there, and one more gene is where is it? Okay, HER2. Okay, HER2. These are proto-oncogenes. Okay, and what are tumor suppressor? P53 and retinoblastoma gene. Angiogenesis is driven by VEGF. This we have seen in healing chapter also, and aflatoxin causes P53 mutation. Okay, that's it for now. Next we'll go to genetic mutations in cancer in depth. Okay, this topic is very crucial to memorize. Okay, that's why I have given a lot of images in this. Okay, so this is what we discussed so far. Okay, there is something called as oncogene, and there is something called as tumor suppressor gene. So oncogenes, basically they are gas pedal, that is accelerator. You can see here, right? Okay, so these three examples we have seen. One is KRAS. Okay, KRAS, what happens is there is something called as GTPase enzyme. Okay, it switches on GTP, which causes cell proliferation. Okay, so this GTPase is activated by KRAS, and this KRAS mutations cause cancers of colon and lung cancers. Okay, so this both are involved with KRAS mutation. Similarly, HER2 causes amplification of hormonal signals, so it is seen in breast cancer. Okay, targeted therapy we have for HER2 cancer, that is nothing but the very famous drug, that is trastuzumab. Okay, next coming to BCR-ABL, what is the problem here? We have seen today morning in the like CML class, that is tyrosine kinase fusion. Okay, tyrosine kinase is activated, because of which we have CML. Okay, CML is classic example of BCR-ABL Philadelphia chromosome, and we have TKI therapy. What is that called? Yes, tell me, what is that called? Imatinib. Okay, very good. So next class of tumor suppressor genes we have these, which are the breaks. Okay, so here the function is lost. So important one, there are two things. One is TP53 and second is APC. TP53 is known as guardian because it is the main responsible molecule. It is the main responsible substance for genomic stability. Okay, the moment it is mutated, okay, everything goes haywire. Many cancers are involved in TP53 mutation. Okay, and APC, that is nothing but adenoma. A is for adenoma. Can you see this mnemonic? A for adenoma. And you can see on this A multiple small colonic pieces are there. Okay, intestinal pieces. Okay, so that is for adenomas. Okay, so that is seen in colon and adenoma, and it is known as gatekeeper. That's why this is made as a gate. Okay, so each and every image has a meaning over here. Similarly, in RB1, that is for retinoblastoma, what you are seeing here is actually cell cycle. See, this is the cell cycle. Okay, so because this involves in cell cycle, that is G1 to S phase. Okay, this is between this phase, this RB1 is a checkpoint. Okay, so if that mutation occurs, then cell cycle will progress unchecked. Okay, so that is the reason. Now, there is one more category of oncogenes, that is DNA, not oncogenes, reason for carcinogenesis, that is DNA impairment. Okay, DNA repair impairment. So mainly we have two categories, BRCA1 and MLH. Okay, so in BRCA1 what happens is two strands of DNA should recombine. Okay, but this is maintained by BRCA, but if there is any mistake in BRCA, no, so this homologous recombination defect is there. Okay, so now what happens, this will lead to breast and ovarian carcinomas. Okay, similarly there is mismatch repair. See, this protein MLH1 and MSH2, this causes repair of this mismatched DNA strands. If this is mutated, then colon cancer, especially Lynch syndrome. Okay, Lynch syndrome, we'll say it. Okay, so also there is one more thing I wanted to tell you. Yes, here MSI. What is MSI? MSI is microsatellite instability. Okay, this is also seen in Lynch syndrome. Okay, this is also seen in Lynch syndrome. So MSL, MSI, MSH, whatever related to M, S and all are related to Lynch syndrome. Okay, just remember it like that. One specific mutation called BRAF V600E is seen with melanoma, and this has a targeted therapy. That's why this question has been repeatedly asked. And this specific drug is vemurafenib. Okay, vemurafenib. I don't know how much you can remember this, but this question has been asked. Okay, so I think I have gone through all the explanation content in the image. So let's solve questions. So oncogene KRAS activation leads to colorectal cancer. Okay. Next, oncogene CML tyrosine kinase, which gene is involved here? BCR-ABL gene. Okay, translocation. Okay. Next, which repair causes MLH MSH? I told you mismatch repair. So this is mismatch repair leading to which syndrome? Lynch syndrome, seen in colorectal carcinoma. BRAF V600 is seen in melanoma and also in thyroid cancer. All this will come again. Okay, we'll be revisiting all this. TSC1, TSC2 mutations are seen in this is seen in hamartoma. Okay, NF1, that is neurofibromatosis 1, is involved in RAS pathway. Okay, RAS activation. RET mutation is seen in MEN2 syndrome. Okay, so these are some questions which are repeatedly asked. That's why I have made it fill in the blanks. If RTK amplification is there, you have to consider trastuzumab. Now, what is RTK? RTK is nothing but tyrosine kinase only. Okay, tyrosine kinase. Trastuzumab. Okay, that is HER2 pathway. Okay, so everything is clear about oncogenes. Okay, next we'll go to one more cancer, that is malignant melanoma. Okay, so melanocytes are the reason for melanoma, and these are derivatives of neural crest cell. Okay, this is the origin of melanocyte. Now, neural crest cell, they migrate to the skin to form melanoma. Okay, now what happens in melanoma is there is UVB lights. Okay, I have told it before also. They undergo DNA mutation. Mutation most common because of UVB is BRAF V600E, because of which melanocytes increase. They invade the depth. Okay, this depth with which they go, no, from the superficial epidermis to the deepest point where malignant cells are there, that is known as Breslow index. Okay, and then they metastasize to the lymph nodes and other organs. Okay, so this is how melanoma progresses. Now, how to know melanoma is dangerous or not, like how to differentiate it from mole is, see, all these things which are given in red, no, they are regarding melanoma. Okay, so melanoma will be ABCDE, that is asymmetrical, see, and it will be irregular borders. it will have a variegate, that is different colors, it will be more than 6 mm, and it will be changing its evolving, okay, it will be changing its shape and all. So there are basically two types. One is superficial spreading, there are other types also I will be telling. Superficial spreading melanoma, and one is acral or lentiginous, okay, that is in the non-sun exposed area. So see, there are two types of ways in which it can spread, okay. One is pagetoid spread. Pagetoid means it is vertical, so whichever melanocytes are there here, they will go to the epidermis, okay. This is the vertical spreading, that is pagetoid spreading. One more is radial. Radial means horizontal spreading, okay. So basically in acral lentiginous there is radial spreading, and in superficial spreading melanoma there is radial also, as well as there is vertical spreading also, that is pagetoid spreading also, okay. So now there can be some mutation, that is mainly BRAF V600E, which I have already told. Breslow thickness will decide the prognosis. That is, if Breslow index, that is the total depth, okay, this depth, okay, from where the epidermis is until the deepest point of the malignancy, if that is less than 1 mm, then we have excellent prognosis. If it is 1 to 2 mm, we have good prognosis. If it is 2 to 4, it is moderate prognosis, and more than 4 mm is poor prognosis, okay. So that is about Breslow index, which is repeatedly being asked, okay. So what is a sentinel node biopsy? Sentinel node is the first draining lymph node from that site, okay. So if sentinel lymph node biopsy will decide staging, because if it is involved, then it is already stage 3, okay, so it is advanced. So what is there are some rare variants of it which can be asked in INICET. One is what is lentigo maligna? Lentigo maligna is mainly seen in elderly people in sun exposed areas, where you can see in this picture, right? There are like dark spots here and there, okay, in sun exposed area. So they are not spreading, okay, they are not spreading. That is nothing but melanoma in situ, okay, in situ. If it spreads, then we call it as lentigo maligna melanoma, okay, lentigo maligna melanoma, okay. Second is desmoplastic, that is nerve related. These type of melanomas, they spread across the nerve, okay, along the nerve. They have perineural invasion. You can see, no, this part it is mentioned in dark, so that's why I'm saying these images are generated in depth, okay. So every information is there in the image itself. Third is this acral mucosal melanomas. They have not BRAF mutation, because this acral and mucosal, no, see this acral lentiginous melanoma, these are not in sun exposed areas, so they have KIT mutation, okay. So these things we can use for mnemonic, remembering things, okay. I think everything is covered. Yes, we have therapy remaining. So we have antagonist of this BRAF V600E, that is nothing but vemurafenib, okay. Remember this phenib drugs, okay. There are new ones also, phenib drugs, okay. You can remember vemurafenib, okay. It is a prototype. So what is the origin of melanocyte? From neural crest cells, okay. Write it down. UV effect, which UV light? UVB light. Mutation, BRAF V600E. Depth, which thickness? Breslow thickness is used, okay. Next, dash mutations in acral melanomas, KIT mutations, okay. And what is used for staging? Sentinel node biopsy. So the question will be like, what is the investigation of choice for staging of melanoma? So answer is sentinel node biopsy, okay. Moving on to next process, that is metastasis. I think this is a very common question, so I won't go in depth, okay. So there are only two things we need to realize, that is, one is carcinomas use lymphatic route for spreading. Sarcomas, that is soft tissue tumors, they use a hematogenous route for spreading. So for sarcomas, it is mainly lung and liver through hematogenous. For lymphatic, it is through lymph nodes, okay. So first drainage site is lymph nodes. Then ovarian carcinoma uses transcoelomic route, that is inside the peritoneal cavity, okay. Other than that, you know already what is sentinel node biopsy. You put dye inside the first draining lymph node and see whether metastasis has occurred to that or not, because that will guide you the exact staging, okay. Rest of the things are very general. I think you can go ahead with it, so I don't think there is need for me. Okay, one more thing is this invasion, that is when do we tell that metastasis has occurred? There should be some form of invasion, a cell invasion, that occurs when there is E-cadherin loss, okay. So which molecule is involved with the metastasis, that is invasion, okay, that is E-cadherin, okay. So invasion, E-cadherin exit, okay. So that is how we remember. So carcinomas commonly use which route? They use carcinomas use lymphatic route, okay. Sarcomas use hematogenous route. Next, molecular loss of what promotes invasion? Loss of E-cadherin promotes invasion. First lymphatic drainage site is known as sentinel lymph node, okay. Next, prostate classically metastasis. This is a very important question. Because people think prostate metastasis to maybe liver or maybe lungs and all. No, it metastasis to bone. Okay, prostate is a bone, and it doesn't cause osteolytic lesions. It causes osteoblastic lesions. Okay, Krukenberg tumors are metastasis. So Krukenberg tumors are ovarian metastasis. Okay, so basically it comes from gastric carcinoma. It migrates to the ovary. So it is ovarian metastasis. Okay, metastasis to the ovaries. Okay, loss of E. cadherin causes invasion. Okay, fine. So we'll go to the next topic, that is neoplasia. I think this is also a simple thing. You can go through it. There is nothing more that needs explanation. Next is sarcoma classification. Okay, sarcoma will go a little bit in depth. There are questions asked on this. Okay, going ahead with sarcomas. So basically sarcomas are tumor of mesenchymal origin, that is soft tissue origin. Okay, so mesenchymal stem cell, they'll differentiate into bone, they'll differentiate into soft tissue muscle, they'll differentiate into vascular. So we have tumors in all these headings. Okay, so from muscle we have rhabdomyosarcoma, and rhabdomyosarcoma mainly that is skeletal muscle that occurs in children only. Okay, so this much you have to remember. Then you have soft tissue muscle like leiomyoma and leiomyosarcoma. Sorry, sarcoma we are telling. So leiomyosarcoma mainly seen in uterus, and then we have liposarcoma, and then we have fibrosarcoma, we have synovial sarcoma, we have Ewing sarcoma. Okay, so remember these are the most important for NEET PG aspect. Okay, so in bone and cartilage we have two very important and which you need to differentiate. One is osteosarcoma, and second is chondrosarcoma. Okay, so osteosarcoma mainly it gives sunburst appearance on radiology, and this you have to differentiate from Ewing sarcoma, because Ewing sarcoma gives you onion peel reaction on X-ray. Okay, one more feature of osteosarcoma is Codman triangle, which is periosteal lifting that happens because of the tumor. One more is chondrosarcoma, which is cartilage related. Okay, so cartilage producing tumor, and it occurs mainly in older age group. Osteosarcoma is bimodal distribution. So soft tissue and muscle tumors, you have rhabdomyosarcoma. There are various types of rhabdomyosarcoma. One is embryonal type, one is alveolar type, there is one spindle type also. There is Botryoid type. Okay, so there are many. And in this you will find desmin positivity. There are two more markers I will tell you in the next slide. Liposarcoma is associated with MD-M2 amplification. Just remember this much only. Leiomyosarcoma has smooth muscle origin, and fibrosarcoma, you are seeing fibrosarcoma is from fibroblast. Okay, so you are seeing this histology. This is herringbone pattern. Okay, herringbone means herring is a fish. Its bone, no, like fish bone will be like this. Okay, so that bone pattern is there. That is seen in fibrosarcoma. Okay, now vascular tumors are angiosarcoma. So angiosarcoma, you have to remember two things. CD31 is positive in angiosarcoma. See, CD31 we didn't get in any of the CD markers. We got CD34. CD34 was what? CD34 was, yes, very good. Yes, remember CD34 was pan stem cell marker. Okay, stem cell, pluripotent stem cell was there. No, that was CD34. Okay. Then vinyl chloride is also associated with angiosarcoma. Okay. Next, Ewing sarcoma is associated with the important translocation, that is T1122. Okay, this chromosome looks like 11, no? So Ewing's we are giving it as 1122. Okay, and one more is synovial sarcoma, which is associated with X chromosome. Okay, remember if it is X chromosome association, then it is synovial carcinoma genetics. Okay, so two important patterns of X-ray, one is sunburst appearance and Codman triangle. See this Codman triangle, and this is the sunburst appearance. So this is seen in osteosarcoma. Okay, and onion skin peeling, onion skin lesion on X-ray, that is seen in Ewing sarcoma. There are other differences also which we'll later see. Okay, now very important, carcinoma, sorry, this sarcomas, they don't spread via lymphatic route, they spread via hematogenous route. Okay, so Ewing's E for 11. Okay, you are seeing this 11, no? Okay, that's why E for 11. Osteosarcoma for outburst, that is sunburst appearance on X-ray. Lipo is for lipid. You can remember this however you want. Okay, okay, so let's solve the questions. Codman triangle, sunburst appearance is seen in osteosarcoma. Okay, next Ewing sarcoma is seen, translocation is 1122, no doubt. Okay, rhabdomyosarcoma is desmin positive, but along with this there are two more markers which are very specific. One is myod-D1 and one more is myogenin. Okay, MD-M2 amplification is seen in liposarcoma. Okay, herringbone pattern is seen in fibrosarcoma. Next, angiosarcoma, CD31 positive associated with the vinyl chloride. Okay, vinyl chloride. Next, what shows onion peel reaction? Ewing sarcoma shows onion peel reaction. What is linked to vinyl chloride? Again, I told you, angiosarcoma. Okay. T1122 is again Ewing's. Codman triangle, osteosarcoma. X18, I told X chromosome linked is, which is that tumor which is linked? It is synovial sarcoma. Synovial sarcoma. So basically sarcoma is mesenchyme and carcinoma is epithelial related. Okay, that's why we have gastric carcinoma. We don't have gastric like sarcoma. Okay, we have basal cell carcinoma because it is from epithelial origin, but we have osteosarcoma because it is not related to epithelium. No, we don't have osteocarcinoma. Okay, I don't know if you have noted this thing, but if you have studied your pathology well, you would have known this. So next we'll go to one more important carcinoma. We have finished basal cell carcinoma, we finished malignant melanoma, and one more important thing is squamous cell carcinoma, which we'll be going through. So next topic is squamous cell carcinoma. So in squamous cell carcinoma, the basic progression is because of UV exposure again, okay, UVB only, okay. Along with that, you have risk factors like HPV virus, and also chronic irritation over the skin is also a risk factor, okay. So there is a precursor mutation, and this precursor mutation, as you can see here, this is known as actinic keratosis, okay. This is because of P53. Once actinic keratosis arises and this mutation also occurs, then there will be dysplasia in situ. See, there is dysplastic cells over here, and then the invasion starts, and then basement membrane is invaded, everything, okay. Now I want to ask you a quick question. For this invasion, which molecule is responsible? We had studied. What is the molecule responsible for invasion? Think. Yes, very good. That is E-cadherin, okay. Okay. So what are the other risk factors? One is UVB exposure, HPV. Which types of HPV? There are two types. One is 611 and 1618. So this 1618, okay. So how do you remember? That is 16 and 18 are teens, right? So risk is higher in adolescent teenagers, okay. So that's why it is 1618 is high risk, okay. Next, arsenic exposure is also known to cause squamous cell carcinoma, and immunosuppression also promotes your risk factor. Now, how do patients present? It's easy. Your exam question will be like scaly plaques are present, okay, over the skin, over head and neck, over the peripheries, extremities. There are two rare presentations which you should know. One is Marjolin ulcer. What is Marjolin ulcer? If there is already a chronic wound, and because of that wound irritation, one ulcer comes out of that squamous cell carcinoma. That is known as Marjolin's ulcer. And lip squamous cell carcinoma has very high rate of metastasis. Okay, so lip squamous cell carcinoma is very dangerous. On pathology, what you'll see, one is keratin pearl. Can you see here? There is a pearl and there are keratin fibers around it. Okay, so this is known as keratin pearl. Second is you can find invasive nest of cells in the epidermis, see, so in the dermal layers, okay. So this is the epidermis, and here you can see the whole epidermis. Here you can see invasive nest of cells, okay. So next is what treatment? Treatment is basically surgery, and it is not chemotherapy, it is mainly radiotherapy, okay, because it is present on the surface, okay. Next is prevention is again using sunscreens and all that, okay. Next you can use these mnemonics to remember things, okay. We'll move on to the fill in the blanks. So first is, what is the precursor? Precursor lesion of squamous cell carcinoma is actinic keratosis. Actinic keratosis. Which mutation is common? P53 mutation is common. Concentric keratinization, which is hallmark of SCC, is known as keratin pearls. Next, HPV link. What is HPV link? Types which one? 16 and 18. Why 16 and 18? Because these are teenagers are high risk. Next, if squamous cell carcinoma occurs in chronic wound, it is known as Marjolin ulcer, okay. What exposure increases squamous cell carcinoma risk? It is arsenic exposure. Which squamous cell carcinoma metastasis earlier? Lip carcinoma, okay. Next, HPV 1618 is related to anogenital squamous cell carcinoma, okay. So that's it. We'll move on to the next topic. One more point which I left out is field cancerization. So what is field cancerization? See, because of carcinogen exposure on that skin area, okay, multiple cancers can arise from that area, okay. It is like soil where there is some pollution, crops will die, no. Similarly, it can happen in many areas in that field. Similarly, in that area, that is field area, wherever that carcinogen exposure has occurred, multiple squamous cell carcinoma can originate. That is known as field cancerization, and that field cancerization will require broad surveillance, okay. So I thought it better to mention it. What if it is asked in your NEET PG, okay. So tumor markers will be going through next. Okay, so tumor markers is a topic for which this whole book, this whole PDF of visual guide was made for. Okay, because when you see things, you don't forget. That photogenic memory is very important. So we'll go one by one. Okay, so you see here, what is this? AFP. AFP, A stands for alpha. Okay, remember this as alpha. Now alpha means something which is in the beginning. Okay, alpha means beginning. That is the meaning of Greek word. So alpha means yolk sac, egg, whatever is there, no, egg yolk, that is the beginning of a hen. Okay, hen or for a chicken, the beginning part is the egg. Okay, so that is yolk sac. Second is alpha, second letter is L, right? So L stands for liver. Okay, so when you see this now, AFP, automatically your mind should go towards hepatocellular carcinoma, HCC, and second it should go for yolk sac tumor. Got my point? So it should be very easy to remember. Second, beta HCG. See here, beta HCG. So beta HCG is all related to genitalia, that is uterus and testicular tumors. Okay, so testicular tumors and uterine moles, that is gestational trophoblastic diseases. This is related to that. Okay, hereditary mole. Third is CA125. CA125 is related to something like this. See, there is a mnemonic here, CA125. Just remember this. O, inside that you have ovary, and there is a 125 calendar hanging on. This is nothing but CA125 is for ovarian mass. Okay, CA199 is for pancreas. See here, pancreatic mass, so it is pancreas. Next, CEA. Okay, see, these things can be very confusing. CA125, I think there should be no confusion. You saw this diagram, just fix this picture in your mind. Okay, next is CA199. CA199 is for pancreas, and CEA, carcinoembryonic antigen, that is for colon also, it is for pancreas also. So pancreas is common for both, but colon is one extra for CEA. Okay, PSA, prostate specific antigen, you don't need anything to remember. Calcitonin, see C, these are medullary thyroid cancer cells. Okay, that is C cells. Okay, so these produce calcitonin. Okay, so calcitonin is for medullary thyroid carcinoma. Next, LDH. LDH is for one is lymphoma, leukemia. Okay, this is a lymph node. Okay, so leukemia, lymphoma. And second is whenever there is tumor burden. Okay, like for example in tumor lysis syndrome, that time also LDH increases. Bench-Jones lytic lesion, you know, this is multiple myeloma. Chromogranin A, see, this is chromogranin A. Are you seeing this chromogranin A? This is the staining pattern of chromogranin A that is seen in neuroendocrine tumors. Neuroendocrine tumors like pheochromocytoma, neuroblastoma. Okay, there you will see chromogranin A positivity. Now some extra points which can be asked, that is CA15-3. What are the three CS which we saw so far? Let me write you down. One is CEA, one is CA19-9, one is CA125, and now we are seeing CA15-3. Okay, so what is CEA for? Colon plus pancreas. CA99 is for pancreas. CA125 is for ovary. This you will never forget. CA15-3 is for breast. Okay, so this is for breast carcinoma. Next, NSC. NSC is non-specific esterase. You can see this image. See, now you will never forget when you see NSC and then this lung tumor. Okay, so small cell lung carcinoma, and metanephrines, it is in pheochromocytoma. So where you will go wrong is you will think that tumor markers are used for diagnosis. No, it is not used for diagnosis. It is mainly biopsy and FNAC that is used for diagnosis. Tumor markers is just for monitoring things. Okay, second is this PSA, prostate specific antigen. It can be increased in BPH also. It can be increased in prostate cancer also, but in prostate cancer the elevation of PSA is very high. Okay, in prostatitis and in BPH it will be mildly elevated only. Okay, next, CA125 told it is not in colon. Okay, in colon it is CEA, remember this, and in ovary it is CA125. Now, how to use this tumor markers? It especially helps in knowing whether there is any recurrence or not, and trend of this is important, not absolute value. Okay, so trend of, what is the trend of tumor markers, that is more important. Okay, so now let's attempt question. Now it should be very easy for you. See it again, see this thing, and do a thing. You take a photo of this and you paste it on your study table so that you never forget these things. Okay, so HCC and yolk sac tumor, very good. What is it? Alpha. Alpha is what? Alpha fetoprotein. Next, choriocarcinoma, germ cell tumors. Okay, choriocarcinoma, gestation trophoblastic disease, all those things. Okay, germ cell tumor, that is mainly testicular tumors. What is increased? Beta HCG. CA125, you saw that calendar. CA125 is written over that, and there is one O. So CA125 is for ovarian cancers. CA199, okay, CA199 is for pancreatic, okay. Next, medullary thyroid carcinoma. What is that? Calcitonin. Remember the thyroid with the C written in that, okay. So it is medullary thyroid carcinoma. Next, chromogranin A is for neuroendocrine tumors, okay. CA15-3, we saw separate small box. CA15-3, it was for breast carcinoma. NSC is elevated in, I said lung, so small cell lung carcinoma, okay. So one more thing is, if pancreatic mass is there, what is that? CA19-9. Also carcinoembryonic antigen, both will be elevated. So how is it? How is the mnemonic? How is the visual mnemonic? It's easy, right? This is how you are supposed to study, not just mug up things, okay. You will be able to remember this for a very long time. Next we'll go to tumor suppressor genes, okay. We'll remember it in a similar fashion only. Okay, so let's go to tumor suppressor genes. So basically you have to see at this image, okay. So there is something called as two-hit theory, okay, and this is a prototype for retinoblastoma when we explain, okay. It is also explained for colon cancer also. So first break is when it is hit, there is a mutation in hit one break is lost, and when second break is also lost, that time it goes out of control and causes all this metastasis, everything, dysplasia, everything goes out of control. So we'll be seeing these breaks and all, okay. So whatever is written in these are like tumor suppressor genes only. All are tumor suppressor genes. There are no proto-oncogenes, okay, like KRAS and MYC gene, then BCR-ABL, all those were proto-oncogenes, but these are tumor suppressor genes, okay. So first one is the guardian, which is nothing but P53, okay. P53 is the guardian and it is involved in DNA repair. Multiple cancers are linked to this. Second is RB1, that is retinoblastoma gene, and this is linked to G1S cell cycle, okay. That's why this traffic, okay. So it regulates traffic at cell cycle, and defect in this causes retinoblastoma. Next is APC. I have told you APC, A stands for adenoma, and over this A there were colonic small pieces, okay, colon pieces. So this is the gatekeeper, and this is involved in WNT pathway, okay. Remember just WNT, okay. Next is BRCA1 and 2. So BRCA and BRCA is involved in homologous repair. If you remember, there were two things involved in DNA repair carcinogenesis. One was BRCA, and second was what? Second was MSH, MLH, okay, mismatch repair, okay, if you remember, in Lynch syndrome, okay. So this BRCA causes breast and ovarian carcinoma. Next is P10. P10 is involved in endometrial, okay. When we go to endometrial cancer, you will remember at that time, it is P for P, okay. So P for PI3K, okay, just remember this. Next is neurofibromatosis. It is RAS pathway, okay, RAS, it causes neurofibromatosis. And VHL is regarding HIF, okay, that is hypoxia inducible factor, and that is associated with renal carcinoma. So these are basic things that you must remember for NEET PG, okay. So I think I have explained all this, okay. This one now, clinical syndromes associated with this tumor suppressor gene: TP53 leaf Romini, P10 Cowden. P10 is involved in which? Endometrial carcinoma. So along with this, you will get skin hematoma, skin tags, etc. Okay. TP53 is most common cause for this familial cancers. Okay. You can see this pedigree chart, and everyone is affected with cancer, different types. Okay. Next is APC. APC is for adenoma. Okay. And in this, you will get FAP. Okay. FAP is familial adenomatous polypi. Okay. So you get hundreds of, this is nothing but hundreds of polyps. Okay. In the colon. So there are some applied aspect. One is this BRCA mutation. BRCA mutation, you have a specific PARP inhibitor, okay, which was asked. This PARP is known as olaparib, okay, and there is its successor also. So olaparib, okay, PIB. So parib, if it is there, so PARP inhibition, okay. Just remember like this, PARP inhibition, okay. So let's fill in the blanks. DNA repair apoptosis, what is the guardian? P53 is the guardian. RB1 is controlling at which checkpoint? G1 cell cycle to S phase of cell cycle. APC is related to which pathway? I said APC, adenoma, FAP, all those are correlated. This is related to colorectal cancer, and which pathway it is? It is related to WNT pathway. Next, BRCA is related to DNA repair. What DNA repair? Homologous DNA strands repair. Okay, remember now. One more was mismatch repair. That was MLH, MSH. Okay, that was related to Lynch syndrome. Okay, so that was mismatch DNA repair. P10 is related to P for P, I told, and EN is for endometrial carcinoma, okay, endometrial carcinoma, and it is related to Cowden syndrome. Remember, no? Okay, so that's related to PI3K. RAS pathway is for neurofibromatosis. SMAD4 and CDKN2, yeah, these are new things. You can remember if you can. SMAD4 is for TGF beta signaling, okay, TGF beta signaling, and CDKN2 P16, that is related to melanoma. If you can, you remember, because this is not as important as BRAF V600E, okay. Next, 2-Heath hypothesis is for retinoblastoma mainly. Which syndrome is for TP53 mutation? Lee-Fraumeni, okay, familial TP53 genetic mutation. P10 is related to Cowden syndrome, where there is hematoma, endometrial carcinoma and all, okay. BRCA tumors responds to PARP inhibitors. So if you take this PARP inhibitors, no, PARP inhibitors, so that's how you get the name PARIB, okay. PAR and IB, PARIB inhibitors, okay. So the example is olaparib, okay. So no doubts regarding tumor suppressor J. Next we'll go to viral oncology. Let's now move ahead with the viral oncology. So we need to know one-liners in this, because this can be asked in INICET and NEET PG, okay. This entire thing is only consists to the part that virus enters and it integrates with the DNA, and then it causes oncogenic transformation. So important viruses are, one is HPV, okay, human papilloma virus. It causes cervical, anal and oropharyngeal carcinoma, and two varieties, that is 16 and 18 subtypes, are associated with carcinoma. So this has two proteins, okay, one is E6 protein and another is E7 protein, okay. Both are of HPV only. Now E6 protein degrades P53, E7 is behind retinoblastoma. Now how to remember, because many students make mistake in this. Remember that 6 comes before 7, right? So similarly P comes before R in alphabet series. So 6 is P53, 7 is retinoblastoma, okay. So there shouldn't be any confusion. Next is Epstein-Barr virus causes Burkitt's lymphoma also. It can cause Hodgkin's also, and nasopharyngeal carcinoma also, okay. Next, hepatitis B and C causes hepatocellular carcinoma, HTLV, T-cell lymphoma, and TAX gene, okay. TAX gene is implicated in that. Kaposi sarcoma, LMP1 molecule is implemented in this. You have to just remember this, nothing else, okay. Now coming to this, what is this? These are coilocytes, okay. Coilocytes, these are the epithelial cells, cervical cells in HPV infection, okay. Next, TAX1 gene is associated with HTLV, which causes T-cell leukemia. Oropharyngeal carcinoma in young person is associated with HPV, and vascular tumor is Kaposi, okay. So we'll fill in the blanks. HPV 16, 18, okay, causes these type of cancers. Next, HTLV is implicated with TAX gene, causes T-cell leukemia. Kaposi sarcoma is caused by HHV8, that is human herpes virus 8. Merkel polyoma virus causes Merkel cell carcinoma, okay. E6 P, okay, 6 for P, 7 for R, okay. So that is how you remember. Next, what causes post-transplant lymphoproliferative disease? EBV causes, okay, EBV, Epstein-Barr virus. HHV8 also is involved in primary effusion lymphoma, okay. That is also Kaposi sarcoma and primary effusion lymphoma. One more, if oropharyngeal carcinoma in young non-smoker, then always it is because of HPV, okay. Moving on to the next topic, that is BPH, benign prostatic hyperplasia. So we are going towards systemic pathology now. Okay, so next topic is BPH, benign prostatic hyperplasia, okay. So you should know before you go that there are two zones of prostate. One is peripheral zone and another is the transition zone, okay. So this transition zone is a periurethral zone where this around the urethra, okay. So in this zone we'll get BPH, because prostatic cancer we get in peripheral zone, okay. Here we get prostatic cancer, BPH we get in the transition zone, okay. So this image should always be in your head, okay. There is no need of mnemonic if you can remember image, okay. That is called photogenic memory. So what is the normal process of, what is the normal physiology behind it? See, testosterone gets converted by 5-alpha reductase, okay. This is also known as aromatase reductase, okay. 5-alpha reductase. This converts testosterone into dihydrotestosterone, okay. So this DHT helps in growth of prostate. It helps in the transition zone growth, that is stromal gland growth, okay. But during hyperplasia, what happens is there is overgrowth of this and it constricts the lower urethral part, and that's why there is urinary obstruction and symptoms of LUTS. LUTS means lower urinary tract symptoms. Okay. So these lower urinary tract symptoms are hesitancy. Hesitancy means you have to go to micturition. You have to go, frequency of micturition is increased. Okay, you can't hold the control. Then there is weak stream. Then there is nocturia. Night time you are going for passing urine. Then there is hydronephrosis because of lower urinary obstruction, and then there can be acute retention. Okay, so what are the diagnostic clues? One is digital rectal examination. That time you will get smooth and enlarged. Okay, but if it is hard nodular, then it is cancer. Okay, smooth, enlarged is these are the keywords. Okay, and I have made it easy for you to remember via images. And prostate specific antigen, very important, it is mildly elevated. If it is grossly elevated, very high elevated, then it is seen in prostatic carcinoma, not in BPH. BPH it is only mildly elevated. And acute retention, if it is there of urine, then you have to do catheterization to remove that urine. Okay, and then if with the help of finasteride, we'll see what is finasteride, that PSA, that is prostate specific antigen, that levels will be reduced by 50% once we start finasteride. Okay. So what are the treatment options? One is you will try to relax prostate. Okay, that is smooth muscles of prostate, and that's why you use alpha blockers. And which alpha blocker you will use? Tamsulosin. Okay, tamsulosin. So it is alpha 1A receptor blocker. Okay, tamsulosin. There are others also like terazosin, doxazosin. Those are the other examples. One more type of drug, that is which shrinks the prostate, and that is by decreasing DHT. That is, I told you, there is 5-alpha reductase enzyme. So 5-alpha reductase inhibitor or aromatase reductase inhibitor, that is known as finasteride. Okay, finasteride. So finasteride is aromatase inhibitor. Okay, it is 5-alpha reductase inhibitor. Okay, aromatase reductase inhibitor. So definite treatment is surgical, that is TURP. TURP is nothing but transurethral, means you are going through the urethra and you are resecting the prostate, resection of prostate. This is the surgical treatment. So now BPH T, see how T, okay, for T stands for transitional zone of the prostate. DHT is useful for BPH, that is the pathogenesis behind BPH. Once you start finasteride, 50% drop in PSA levels will be there. And on digital rectal examination, you will find a smooth prostate, okay, not hard prostate. So let's go to the question answer session. Zone. What is a zone in which there is BPH proliferation? It is transitional zone. Never forget this. Hormone, dihydrotestosterone. Okay. Treatment, which relaxes smooth muscles? That is, relaxation of smooth muscles is by alpha blockers. And which alpha blocker is the prototype? Tamsulosin. There is terazosin, there is doxazosin. Okay, 5-alpha reductase inhibitor. Okay, 5-ARA inhibitor that shrinks prostate is finasteride. Surgery, TURP surgery is used, transurethral resection of prostate. And on histology, is the histology diagram given? No. Okay, so basically you will find nodules with hyperplasia. Okay, so it is nodular hyperplasia. Okay, next, if hard nodule, think of prostate carcinoma, prostate CA. Rule out what before diagnosing LUTS? Lower urinary tract of symptoms. Rule out prostatitis, inflammation of prostate, and also rule out UTI. Okay, these both conditions you need to rule out. So next we'll go to next topic, that is breast CA, a very important topic, and I'll explain you in depth. We're moving ahead to very important topic from surgical and pathological point of view is breast carcinoma. I know that many of you wouldn't have understood most of it during watching your main videos, lectures, or even during your MBBS days. So basically I'll make it very simplified for you. Breast carcinoma is classified based on histological type and based on molecular type. Okay, so histological type we have based on when you do like slide on pathology, this one, no, HND. So what are the types of breast carcinoma? You should know only two important types. That is, one is invasive ductal carcinoma, which is the most common. Okay, invasive ductal carcinoma, and next is invasive lobular carcinoma. These are the two types you should know. This is the most common, and invasive lobular carcinoma is associated with invasion. So there is E-cadherin loss. Remember, E-cadherin is for invasion. Okay, that is basement membrane invasion. Next is DCIS, that is ductal carcinoma in situ. This is a relatively benign form. this has microcalcification, because this MCQ has been asked, that's why I have included this point. Okay, so this much you remember regarding types of breast cancer based on histology. Now what actually matters is how they're classified based on receptors. Now why receptors? Because these receptors guide therapy in breast carcinoma. We have mainly 4 types. The most favorable type in this is luminal A. So for every breast cancer, we have 3 types of receptor. One is ER, estrogen receptor, PR, progesterone receptor, and HER2. Okay, HER2. So if ER is positive, PR is also positive, and HER2 is negative, this is the most favorable type, and this is known as luminal type A. Okay. Now, what if ER is positive, PR is positive, but HER2 is plus or minus? Then it is slightly like aggressive type. Okay, not that much aggressive also, but it grows fast. It is known as luminal type B. Okay. Now, if ER is negative and PR is also negative, but HER2 positive, then this will respond very well to a new novel drug, that is trastuzumab. So this is known as HER2 enriched breast carcinoma. And what if all these are negative? Then it is triple negative. So this is highly aggressive because you don't have any receptor only for the drug to act. So definitely it is going to be aggressive. Okay. So what are the symptoms of breast carcinoma? Mainly there will be painless lump, there can be nipple changes, there can be axillary lymph node spread, okay, and then there can be genetic risk associated with BRCA mutation. Remember, BRCA is for what? BRCA is which carcinogenetic step? It is DNA homologous repair defect. Okay, remember, no? Yeah. So next, how do we screen once breast cancer is suspected? First, we will do a palpable screening. This is very important, palpable lump, and you do clinical examination. Then you go for imaging with mammography. In high risk cases, you go for MRI. Then you go for core biopsy, and then you go for receptor testing, ER, PR, and HER2 status. And finally, you do the staging based on node status, and then you do PET CT to identify where malignant cells are metastasized. Okay. So if ER and PR are positive, estrogen and progesterone receptor, then you have endocrine therapy. If HER2 is positive, then you have trastuzumab, and if it is triple negative, then it is slightly advanced, so you will have to go for some advanced options. Some easy things to remember are, like, for example, in lobular carcinoma, you remember, no? Invasive lobular carcinoma, this one, okay? There you see how the cells are arranged. They are arranged in a line, no? So L stands for line, okay? That is for lobular, that is single file cell appearance on histology, okay? And one more is PUD orange. Now, what is PUD orange? The tissue, the skin over the nipple areola complex that appears like an orange skin peel. This is seen in inflammatory type of carcinoma. This is one more type of carcinoma of breast, inflammatory, and this is the most aggressive type. Okay. Next, Paget's disease of nipple. I'll tell you in the the fill in the blank section. What is the strongest predictor of prognosis, which will tell you whether the disease is advanced or not? That is the lymph node status, how many lymph nodes have been involved. And very important thing, aromatase inhibitors are used in which type of carcinoma. So for that you should know what is the status of ER and PR. So ER is estrogen receptor. So if a woman is pre-menopause, before menopause, okay, we use selective estrogen receptor modulator, that is SCRM, and example of this is tamoxifen, okay. And if it is PR positive, and if it is a post-menopausal woman, okay, ER and PR positive post-menopausal woman, we use aromatase inhibitor. Now, what is the idea behind this? Okay, why do we use aromatase inhibitors in post-menopausal? Example for aromatase inhibitor is letrozole and anastrozole. Okay, letrozole and anastrozole. Now, why this differentiation? That is because in post-menopause, say what will happen is ovaries. Okay, ovaries are a source of estrogen. Okay, and there is one more source of estrogen, that is testosterone gets converted into estrogen with the help of aromatase inhibitor. So now what happens is in pre-menopause, ovaries also will secrete this from androgen. Aromatase inhibitors also will convert testosterone to estrogen. So there are two sources. So this aromatase inhibitor alone blocking won't help us. Okay. That's why we use selective estrogen receptor modulator, which acts on the receptor itself. That doesn't decrease estrogen production, that directly acts on the receptor. That is why tamoxifen. But in postmenopausal women, this source is not there because estrogen is decreased in postmenopausal women. So the only source of estrogen is through testosterone, that is conversion by aromatase inhibitor, and that's why we use letrozole and anastrozole, which act on this aromatase inhibitor. Okay, so this is one important concept you should know, which helps you solve MCQs. So let's go to solving MCQs, solving questions. So which nodes are involved first during metastatic spread? First nodes that are involved is axillary group of lymph nodes. What is the most common type of breast carcinoma? That is invasive ductal carcinoma. Invasive lobular carcinoma is associated with loss of E. cadherin. HER2 positive status response to trastuzumab. Now you should also know that along with trastuzumab, we also give one more drug, that is pertuzumab. Trastuzumab and pertuzumab, okay. And if it is triple negative, they are very aggressive. And here you have one more drug which has come now, that is for triple negative, pembrolizumab, okay, pembrolizumab. Next, which disease involves nipple epidermis? Paget's disease of breast, Paget's disease. Which carcinoma causes PUD orange? Inflammatory breast carcinoma, okay, inflammatory. BRCA1 is linked to which tumors? Triple negative. This is important thing. Triple negative tumors are linked with the BRCA mutation. That's why it is very aggressive. That's why we do prophylactic oophorectomy, prophylactic mastectomy also. Next, E. cadherin, and also genetic counseling is also very important. E. cadherin loss is associated with the invasive lobular carcinoma. Microcalcification is seen in ductal carcinoma in situ, okay. And then which is the strongest prognostic factor? It is the lymph node status. How much has been spread to the lymph node? MRI is used in high risk women. Which investigation we use to see the progression of node status? We'll use PET-CT. Okay. So this is all about breast carcinoma you should know from pathology. Some extra points also from PYQs you can add on to this. Next we'll go to colon cancer. Okay, next is colon carcinoma. So we'll first go to the genetics of colon cancer. That is, first there will be here what we'll say is 3-hit model. Okay, just I have given this name. Okay, 3-hit, because we are having 3 hits and then only colon carcinoma will occur. Okay, so first is APC. You remember APC? A stands for adenoma, and their colon pieces were there on that. Okay, so that is what is implicated here. Okay, APC loss, and it is also known as gatekeeper of the genome. Okay, so this is the initiation phase. Once APC loss is there, it will cause adenoma and polyps. Upon this, if there is KRAS mutation, remember KRAS was also for colon cancer. So if there is KRAS and it was a proto-oncogene, if you remember the slide on proto-oncogene, you will remember KRAS, then ABL's BCR. Okay, all these were proto-oncogenes. Okay, and with the KRAS mutation also, it will cause dysplasia. And once P53 loss occurs, then it will turn into carcinoma. There is one more pathway, that is mismatch pair effect. Okay, there were 2 types in DNA repair. One was BRCA. BRCA was related to homologous DNA repair, and MMR defect is what? Mismatch repair. Okay, so that is associated with Lynch syndrome. Here there are sessile means small, serrated, see serrations, serrated adenomas. Okay, and this leads to MSI. MSI is microsatellite instability. Just remember this word, microsatellite instability. High grade carcinoma, okay, so which are lymphocyte rich also. So this is one more pathway of colon cancer. There are 2 pathways. Now what will be the symptoms? Very simple. There can be right sided symptom or left sided. If it is right sided, then it will be bleeding ulcer and iron deficiency anemia because of bleeding. If it is left sided, it is related to obstruction. So there will be narrowing. So there can be bowel obstruction, or there can be altered bowel habits. Because of this obstruction, stools will be pencil shaped thin stools. Okay. So what are the risk factors? Age more than 45 years, diet high in red meat and low fiber, ulcerative colitis, that is inflammatory bowel disease, polyps, villus or tubular. So that's why screening is required. Start at 45 years and then screen every 10 years for those with high risk. Okay. Next, on diagnosis, what you will see? You will see on biopsy malignant glands which are invading the stroma of the intestine. Okay. And on molecular testing, you will do for KRAS, NRAS, BRAF, all these mutations you will do. And then what is this EGFR therapy? I'll tell you. Okay. So remember, we had one molecule called a CEA in tumor markers, and this CEA was involved for colon cancer. Okay, for as tumor marker. Okay. KRAS is the genetic mutation. CA is the tumor marker. Next, there is aspirin. For some reason, is associated with decreased risk of. So aspirin is associated with reduced risk of colon cancer. Lynch syndrome is early onset, okay, and you need to do mismatch repair genes testing, okay, mismatch repair genetic testing. Adjuvant chemo. What is adjuvant chemo? Adjuvant chemo means after surgery, like this is the colon cancer, you are removing the tumor. Now since it is stage 3, stage 3 means it has spread to the lymph nodes. So now for residual disease, you will give chemotherapy despite after doing surgery, okay, that is known as adjuvant chemo. And post polypectomy will be doing surveillance also. So let's go to the fill in the blanks. Okay, what is the pathway? First comes APC, that is adenoma. Next comes KRAS, and then comes P53. So no doubt in that. MSI is related to Lynch syndrome, microsatellite instability, and that comes under mismatch repair. Okay. Iron deficiency anemia is seen in right-sided colon cancer. Obstruction and altered bowel habit is seen in left-sided colon cancer. Screening starts at 45 years. Next, polyps. Polyps with dysplasia. Okay, they undergo malignant transformation after next hit. Okay, what is anti-EGFR response? See, basically, whenever this KRAS mutations are there, no KRAS mutation, that time this EGFR, okay, this growth factor receptor inhibitors, okay, example for this is cetuximab, okay, cetuximab has very good response. Okay, so this EGFR, which predicts anti-EGFR response, is seen where KRAS is normal. Okay, KRAS normal will give anti-EGFR treatment, that is cetuximab. Metastasis occurs first to liver. Why? I said first carcinoma. Carcinoma spreads through lymphatic. Now from intestine, lymphatic goes to where? Liver. You know how lymphatics carry this lipoproteins, all these fat molecules to the liver. Okay, that's why. Sessile serrated adenomas are related with the MSI pathway. Okay, microsatellite instability. Lynch tumors, DASH reduces CRC risk, that is colorectal carcinoma risk. Aspirin reduces. Next, if early onset, what you should test? You should test for mismatch repair genes. Okay, anti-EGFR resistance is there. If there is resistance for anti-EGFR, EGFR will work only if there is normal KRAS mutation. Then you should suspect KRAS, some other mutation has happened. Okay, adjuvant chemo we use for stage 3 when it has spread to lymph node. So next we'll go to endometrial cancer. So next is endometrial carcinoma. Now I would say that colon cancer and endometrial carcinoma are very closely related to each other. Okay, so there was one point which was related to endometrial carcinoma, if you had noticed, which I told earlier, that is P10 mutation. Okay, I told you P10, EN in P10 stands for endometrium. Okay, and this P10, which pathway is involved? PI3K, P for P. Okay, so if you remember that, we'll go ahead. One more important thing is Lynch. Okay, Lynch syndrome, I told you, is associated with the which mismatch repair, and this mismatch repair is seen in both. One is colorectal carcinoma, that is CRC, and it is also seen in endometrial. That's why if you go to tumor markers, okay, there you will see that in this mismatch repair you will see photo of, not tumor markers, oncogenes. There you will see photo of colon also, and you will see photo of endometrium also. So what is the typical flow chart that you need to know? One is endometrium is a uterine lining. There are two types, okay, type 1 and type 2. Type 1 is E related, estrogen related. Okay, so it is estrogen driven. So estrogen excess, like in obesity, or if there is no ovulation, okay, anovulation, there is high estrogen but no progesterone. Okay, so these both are related with to type 1, okay, because estrogen is in excess. Now this can lead to hyperplasia, it can be atypia, okay, and then it will get converted into glandular endometrioid carcinoma, that is endometrial carcinoma. Now type 2 is related with P, okay, this is E, this is P, this is estrogen, this is not progesterone, this is nothing but P53, okay. This is also known as papillary, or it is also known as serous, okay, papillary serous carcinoma of endometrium, that is type 2. Now this occurs in atrophic endometrium, okay, in later stages, that is after in old age, atrophic endometrium, there will be P53 mutation, and then it leads to serous papillary carcinoma. Okay, this is adenocarcinoma because there is glandular, okay, adenocarcinoma, and this is serous papillary carcinoma. So you diagnose. What is the important step? Again, it is not tumor marker. Remember, it is not tumor marker, it is biopsy. So endometrial biopsy is the gold standard for diagnosis. And then spread and stage, everything depends on how many lymph nodes are involved and how deep the metastasis is, how deep the myometrial invasion is. That determines the prognosis. So you can undergo surgery or you can undergo adjuvant chemotherapy. Now, what is the most common presentation? That is post-menopausal bleed. After post-menopause, there shouldn't be any bleeding. If it is post-menopausal bleed, number one thing that should come to your mind is endometrial CA. So what you do ultrasound, that is transvaginal ultrasound, and you see thick endometrium. Endometrium thickness increases. That depends on which criteria you're using. Are you using ACOG guidelines or are you using FIGO guidelines? Next, endometrial biopsy is the standard procedure for diagnosis. So these are the risk factors. Anywhere where estrogen is increased, like obesity, like tamoxifen. In tamoxifen, what is happening is selectively you're modulating estrogen receptor. Okay, so tamoxifen is a risk factor. And ovulation, as in PCOS. Also in Lynch syndrome, as I already told, with MMR mutation, that is mismatch repair mutations. What is protective? OCPs, because OCPs contain progesterone. Whenever there is progesterone, it is protective for endometrial carcinoma. Similarly, progestin therapy only will give in atypical hyperplasia. Okay, that is, it has not led to carcinoma, but progesterone protects it. Okay, so on histology, what you see is type 1 endometrial, you will see atypical glands and it is P10 positive. Okay, P10 positive is type 1. Type 2 is papillary serous and it is P53. So this is P53 stain that you're seeing. So it's spread and staging, everything depends on how deep the myometrium is invaded. So it is based on myometrial invasion and how much lymph node spread is involved. Okay. Now treatment involves bilateral salpingo-oophorectomy plus or minus along with nodes. Adjuvant chemotherapy or radiation depends on the stage of the tumor. MRI you can use to assess how much depth, myometrial invasion depth. It is not brain MRI, okay. It is myometrial MRI, uterine MRI, okay. And then prognosis depends on what stage the tumor is at. So remember, E is for estrogen, P is not for progesterone, it is for P53. Progesterone is protective, it is not causative. Next we'll solve fill in the blanks. So types, type 1. What is type 1? Type 1 is endometrioid type of endometrial carcinoma. Okay, and type 2 is serous or papillary. Okay, etiology for type 1 is increased estrogen. Okay, estrogen excess. Type 2 is P53 mutation. Type 1 we have P10 mutation also. Okay, next risk factors, you go through that. Presentation, it is post-menopausal bleeding. Okay, PMB we say. Diagnosis is by endometrial biopsy. Remember, it is not by tumor markers, it is by endometrial biopsy. Spread, what is important? Myometrial invasion. Myometrial invasion is very important for spread. Next, Lynch syndrome is associated with which mutation? P53 mutation here. Okay, sorry, with the, it is associated with mismatch repair. Sorry. Okay, sorry. Next, treatment is treatment is hysterectomy. Hysterectomy with the plus or minus bilateral salpingo-oophorectomy. Okay. Now, which carcinoma is very aggressive? It is clear cell. There is one more carcinoma, endometrial, clear cell endometrial carcinoma, that is related with aggressive type. Which mutation is common in type 1? It is P10 mutation. Next, what are protective in because of progesterone action? That is OCPs are protective. And what assesses invasion depth? MRI. MRI is the investigation we use for assessing the invasion, how much invasion has happened through the myometrium. Okay, so as simple as that. So we have finished endometrial carcinoma. Next we'll go to Ewing sarcoma. Okay, next topic, Ewing sarcoma. So basically Ewing sarcoma is seen in children and adolescents, so around 15 to 20 years, like that. Okay, 25 years. So that's why this emoji, okay, this image. So it is seen in long bones. See here, long bones, and it is seen in pelvis. Okay, so these 2 points you should remember with your photogenic memory only. Next, how does it present? It presents as a painful swelling. Okay, painful swelling, and on imaging, what you see, it is onion peel appearance. Okay, onion peel appearance on X-ray. So then you do biopsy. On biopsy, what do you see? You see small round blue cells on histology. Okay, and then you see do genetic testing. In genetic testing, you will see translocation. I told you already, Ewing's E, see this looks like 11, right? So E for 11, and this also looks, this chromosome also looks like 11. Okay, so mnemonic is translocation 1122. And when you do immunohistochemistry, that time you will get CD99 and MYC2 positive. Remember, MYC MYC was for Burkitt's. Okay, MYC MYC was for Burkitt's. This is MIC MYC, this is for Ewing's. Okay, now onion skin reaction is seen in Ewing's. Sunburst pattern and Codman triangle is seen in osteosarcoma. One more important point is Ewing's involves metaphysis. Sorry, osteosarcoma involves metaphysis. Ewing's involves diaphysis. So how do you remember? Diaphysis is towards the end, or whether which is in the middle? Middle is this one, metaphysis. Okay, which is towards the end, diaphysis. No, so end of the bones is Ewing's. E for end, E for Ewing, so E is for diaphysis. Remember like that. Okay, M is middle, middle is metaphysis, end is diaphysis, and end E is for Ewing's. That is how you remember things. Okay. Now, very important thing is, in exam, your one of the option can be osteomyelitis, because this painful swelling of the bone, no, that mimics like osteomyelitis. It feels like this is come because of infection. Okay. So you'll have to rule out osteomyelitis. You have to see for other clues. Okay. Home or right rosettes are occasionally seen. This can be an INICET question. And since this is a sarcoma, there is early hematogenous spread to the lungs. Always remember, carcinoma is through lymphatic, sarcoma is through hematological metastasis. If pelvis is involved, I told you, right, it's either long bone or it is pelvis. If pelvis is involved, then there is reverse prognosis, and chemotherapy significantly improves outcome in Ewing sarcoma. Which chemotherapy is given? All that are not required. Okay. So let's move to the fill in the blanks. Location. What is the site? It is diaphysis. How to remember diaphysis? Diaphysis is towards the end of the bones. End is E. E is for Ewing's. Okay. E is for Ewing's. Next, genetics. What is the translocation? Ewing's E is for 11, 11, 22. Histology, small, round, blue cells. Write it along with me. Small, round, blue cells. Periosteal reaction, what pattern do you get? You get onion peel pattern on X-ray. Okay. Then, what is strongly positive? CD99 or MYC2. This is strongly positive. Pelvic tumors have a very worse prognosis. What positivity is the diagnostic clue? Again, CD99 positivity is the diagnostic clue. Why I have repeated again and again is because these are the important points and these are the things you are supposed to remember. Dash significantly improves survival. Chemotherapy significantly improves survival. It is not radiotherapy and all. It is chemotherapy. Metastasis commonly involves lung. And what investigation delineates whether there is bone marrow involvement or not? It is MRI of the bones. Okay. That's it about Ewing sarcoma. Now let's move on to next topic, that is gastric carcinoma. Okay, so we are going for gastric cancer now. So basically gastric adenocarcinoma has two types. Okay, this is what you should know. One is intestinal type and one is diffuse type. The most specific question that is asked is which is the commonest site of gastric carcinoma? That is lesser curvature. Okay, so see this image. Okay, this image itself is a mnemonic for you. So there are two types I told, intestinal and diffuse type. So intestinal type where H. pylori infection occurs. Okay, and then that leads to atrophic gastritis, and then there is intestinal type of carcinoma that is developed. So these are glandular structures, okay, which turn into carcinoma. Okay, so H. pylori is risk factor and blood group A is also risk factor. Okay, whereas on diffuse type, which is a very dangerous type where Lionitis plastica also occurs, what happens is E-cadherin mutation occurs. So there is E-cadherin loss, and this leads to dispersed cell. Okay, because cells are not connected, so cells will get dispersed, and there is lipid accumulation within, mucus accumulation within this cell that causes signet ring appearance. Okay, signet ring appearance. Okay, because nucleus is pushed to the periphery. Okay, it looks like signet ring, and then that leads to Lionitis plastica, where there is fibrosis and all, leading to rigid thick stomach. Okay, thickened stomach, and then there is diffuse infiltration with poor differentiation. So signet ring E-cadherin loss is related to diffuse type, and intestinal type is gland forming type, that is related to H. pylori. Now, what are the presentation? Presentation is weight loss and early satiety, and CEA is used for monitoring, not for diagnosis. Okay, so which are the lymph nodes that are useful? One is Virchow, that is supraclavicular lymph node. Second is Sister Mary Joseph, that is umbilical lymph node. And third is Krukenberg tumor, that is this gastric carcinoma metastasis can go into the ovary and then it can spread to bilateral ovary, that is known as Krukenberg tumor. Okay, and what is the treatment? Gastrectomy, chemoradiation. Okay, that is adjuvant. After you remove the part of the stomach which has cancer, then that tumor, then you give chemo or radiation in addition to that. Okay, H. pylori prevention has a major role, and you can do CT chest and abdomen for staging. Okay, so there is a mnemonic for diffuse type of gastric carcinoma, that is dispersed. Okay, because of E-cadherin loss. Infiltrating type, it is dangerous type. Fibrosis causes Lionitis plastica. Female predominance is there. Okay, ulceration is rare in this. Okay, because in diffuse there is atrophic gastritis and ulceration, so not diffuse. The first one. Okay, that is intestinal type. Then there is a signet ring cells, and then there is E-cadherin loss. So this one image itself will make you remember everything, and no need of committing mistakes because of this. Okay, so this is Virchow node, Sister Mary Joseph, that is known as belly button, and Krukenberg ovaries. Okay. So imaging clue, you can see thickened wall, Lionitis plastica, and H. pylori, and type A. See, type A blood group is common with this type of carcinoma. Okay. So let's see the fill in the blanks. which type is associated with H. pylori and atrophic gastritis? It is intestinal type, that is type 1. Okay. Type 2 is associated with signet ring cell, and this is diffuse type. So what we are doing is we are associating our memory with images. Which is the most common site? It is lesser curvature. So if I taught you without these images, then it would have been so blatant. Okay, it would have been some other rapid division source which you wouldn't have remembered. Spread, dash tumor spread to ovaries. What is that pattern? Krukenberg. CA is used for monitoring. It is not used for diagnosis. Okay, carcinoembryonic antigen. It is also used in colon cancer, also used in pancreatic adenocarcinoma. So what causes rigid stomach? Linitis plastica. Okay, linitis plastica because of excessive fibrosis. Blood group is A is linked to higher risk. Signet ring cells are seen in diffuse type of cancer, and dash is used for staging. CT chest and abdomen. CT chest and abdomen is used for screening. Next model we are going to go is for glioblastoma multiforme, that is brain tumor. Okay, we'll see important points related to this. Okay, so GBM is basically grade 4 astrocytoma. So lineage is from astrocytoma of the brain. Okay, brain cells. Okay, so it is grade 4. Okay, that is the final stage. So what is the clinical presentation? So it presents as neurological symptoms with headache, seizures and focal deficits. On MRI, what you see is ring enhancing lesion. So there is a ring and which is enhancing on contrast. Okay, so ring enhancing lesion, and this when it appears on the brain, like in this one, say this image. So when it appears near the corpus callosum, it crosses the boundary. Okay, if it is bilateral. Okay, so then it appears like a butterfly. So it is known as butterfly tumor also. Okay, butterfly glioma. So in glioblastoma, there is rapid neurological decline, the headache, seizures, focal deficit progress very rapidly. You do biopsy, that which gives histological confirmation, and you do pathological, you see some pathological findings, and there is multimodal therapy. You resect the brain tumor also, you give radiotherapy, no chemotherapy, radiotherapy, and you give something known as temozolomide, which is actually a drug targeted against specific part of the DNA. It is an alkylating agent. Okay. So what is the pathogenesis? Basically, these are astrocytes in the brain which undergo EGFR amplification. Remember EGFR. There is one more thing where you came across EGFR. Remember EGFR, we learnt about cetuximab. Remember, just 1 hour ago we learnt about this. This is in colon cancer, not even 1 hour, half an hour before. Okay, cetuximab. Okay, that is in colon cancer. So here after EGFR amplification, there is break failure, that is P10, which is a tumor suppressor gene that is also mutated. All this leads to one more thing that is known as MGMT methylation. Okay, I'll tell you what it is, everything. Okay, and IDH, that is, what is IDH? IDH is isocitrate dehydrogenase. Okay, I'll tell you now. Okay, so that will have worse prognosis. And this MGMT methylation, if there is P10 loss, no, that is related to therapy. I'll tell you how. Okay, so coming to important thing, that is ring enhancing lesion can be confused with abscess, or it can be confused with neurocystosarcosis also. So it is always important other clues that are given in MCQ, like butterfly glioma, or biopsy was done which showed this pattern. Okay, second is ring enhancing lesions with necrosis will be there. Okay, with necrosis you should think of GBM. Okay, because in both in glioblastoma we don't get sorry, not glioblastoma, NCC, that is neurocystosarcosis, you don't get necrosis. Next, pseudo palisading. Have you remembered palisading anywhere? Yes, 1 hour back when we were discussing palisading nuclei. Okay, palisading pattern you had seen in basal cell carcinoma. You remember the fence like pattern. So here it is pseudo palisading. See, there is palisading, like fence like pattern is there. But what is this? This is the central necrotic material. Now, how this necrosis happens? That is because of hypoxia, because tumor cells grow so quickly that there occurs necrosis, and because of this there occurs a hypoxia, and because of this these cells are arranged in this pattern. That is because of hypoxia, to prevent hypoxia, and as a result of hypoxia they are arranged in this pattern. That's why it is pseudo palisading pattern. Okay, next there is one staining of on biopsy, that is GFAP. Okay, GFAP staining. So this GFAP stands for glial fibrillary acidic protein. Okay, glial fibrillary acidic protein. If this is positive, then that confirms astrocytic origin. Okay, so that confirms actually glioblastoma, and rapid progression, most likely it is glioblastoma. And IDH, that is isocitrate dehydrogenase. If this mutation is there, then there is poor prognosis. Okay, so what is this? This is microvascular proliferation inside the glioblastoma. Okay, so treatment is mainly resection, that is, you surgically remove the tumor along with radiotherapy, and then you give temozolomide. Now, what is temozolomide? Temozolomide is an alkylating agent, so it methylates. Okay, it methylates DNA of tumor cells and kills the tumor cells. Now, what is the problem with this? If there is something called as MGMT methylation, if there is methylation, okay, then there won't be response to this temozolomide. That is what is given here. That is, MGMT methylation predicts chemo response. Then our temozolomide is not of much use, and median survival is less only. There is poor prognosis. Steroids are useful to reduce cerebral edema because of this ring enhancing lesion and all. Okay, and mostly recurrence will occur in this tumor. Okay, so this is all about GBM, and now we'll go to the MCQs. Okay, so WHO grade 4. Okay, total there are 4 grades. This is the highest grade. Next, mutation occurs because of first which amplification occurs. See here, first which amplification? EGFR. Okay, so first EGFR amplification, and next P10 loss occurs. Now remember, where else did we study about P10? Just now we studied in endometrium. Okay, we also studied it in colorectal carcinoma. Remember, first we had APC, then we had KRAS, okay, then we had P50. Sorry, we didn't had in colorectal. Sorry, we didn't had in colorectal. We had in endometrial only. Okay, sorry. Histology, which type of necrosis? Pseudo palisading type of necrosis. We'll see. Pseudo palisading type of necrosis pattern. Spread corpus callosum. If it crosses, we call it as butterfly tumor. Treatment is resection plus radiotherapy plus what is this name? Temozolomide. Sorry, I confused it with lenalidomide. Lenalidomide, where did we get? One was in MDS, Myelodysplastic Syndrome, and another one was in multiple myeloma. So here it is. What is this name? I again forgot. Temozolomide. Okay, temozolomide. Next, wild type of GBM which has IDH mutation. IDH wild type of mutation has worse prognosis. And DASH predicts chemo response, MGMT methylation. Okay, so remember it has methylation because then temozolomide can't work. What is positive on staining to prove that it is astrocytic lineage? GFAP, glial fibrillary acidic protein, is positive. What reduces edema? Steroids help in reducing edema. So we are going to the last topic of today's that is part 1 of pathology. I plan to do it in one part only, but I need to give you explanation part also, or else you won't understand. I can just brush it off also. For final revision, I'll just brush it off, okay? I won't go in depth, but now you actually need a context. That's why I'm giving you a context. So, intestinal metaplasia means it is conversion of normal gastric epithelium into intestinal epithelium, okay? So, this is the normal gastric epithelium. You can see, the crypts and villi and all, okay? Not villi, okay, crypts. So, this gets converted into intestinal epithelium, okay? That is goblet cells and Paneth cells will start appearing, and we are more concerned about this mucus filled goblet cell. Okay, the moment goblet cells appear in gastric epithelium, we term it as metaplasia. Okay, so what is the marker that we use on microscopy? That is CDX2. CDX2 is only present on intestinal cells. So the moment CDX2 appears in gastric cell, that means metaplasia has taken place. So what is the reason for this metaplasia? One is chronic gastritis because of H. pylori, or there are some epithelial stress adaptations taking place because of which intestinal metaplasia occurs. Goblet cells appear, they undergo dysplasia and then lead to gastric carcinoma. So this is where gastric adenocarcinoma can result because of this. So one is H. pylori and rarely bile reflux. Once it was asked, bile reflux is also a cause. Okay, so this is a precursor for adenocarcinoma. So there are two types of intestinal metaplasia. One is complete and then next one is incomplete. Complete means the intestinal epithelium will become like small intestine type. Incomplete means it will become like colonic type. And this incomplete is associated with higher risk of gastric adenocarcinoma. So what is the location where this intestinal metaplasia is more common? See, from here bile reflux and all will happen. No, most of the things will happen in this area only. So that's why this antrum area is the predominant location for intestinal metaplasia. If I ask you, remember which was the area for gastric carcinoma most common? It was lesser curvature. Okay, so next reversibility is possible. Okay, metaplasia will reverse if H. pylori is eradicated. Okay, so H. pylori therapy is very beneficial, and this is associated with autoimmune gastritis also. Okay, and eradicate early H. pylori, do surveillance for high risk people, and smoking actually increases the progression. So metaplasia is conversion of gastric epithelium into intestinal epithelium. That is that is when goblet cells appear in the gastric epithelium. So let's solve questions now. Morphology: dash cells appear, that is goblet cells appear. Marker: what is the marker? CDX2 positivity. Location: antrum. Okay, antrum is the most common location associated with the autoimmune gastritis. Okay, next, incomplete metaplasia carries cancer risk. Bile reflux increases the risk. May reduce progression. What actually reduces progression is aspirin. For some reason aspirin reduces. Aspirin also reduced colorectal carcinoma, remember. Next, if goblet cells are there, choose the option as metaplasia. Okay, in the gastric epithelium. Okay, if which type has higher malignancy risk? It is incomplete type. Next, which surveillance is for high risk? What surveillance you will do? You will do endoscopic surveillance. And smoking, what happens to smoking? If you do smoking, it will increase the metaplasia risk. Okay, so we have come to an end of part 1 for pathology. Okay, we'll have part 2. We have total 80 topics, so 40 topics we have covered in part 1, 40 topics we'll have for part 2. Now you have known this. Now it's very easy to remember things. Now whatever you have is all your visual memory now, so you don't have to by-heart things again and again. I want you to revisit these images again and again so that you don't forget things. Definitely you won't forget things like this. What you want to supplement along with this is PYQs. Very important, because this entire module doesn't has any question. That's why if you do it with PYQs, you will have a list of all important content, and wherever I have left the space now, like here half page is empty now, so here you write whatever important points are there of PYQs of patho. You start mentioning in this so that you can make this as a very good revision guide for those who don't have any revision guide. Okay, so next we'll be having next upcoming video, we'll be having one more session like this. Okay, so let me know in the comment section. Also let me know in my email if there are any modifications to be made, because I don't think anyone has come up with such an idea where you teach just based on images. Okay, so we'll also start with new modules later on. Also we have a lot of plans right now. Okay, so if you have enjoyed this, please comment in the comment section, and also share it to your friends and your juniors, whoever is willing to go through easy visual memory based pathology. Will do it for all 19 subjects. Thank you.